BRCA, we talked about BRCA 1 and 2. BRCA stands, bless you, for breast cancer, BR for breast, CA for cancer. BRCA 1 or 2 is basically tumor suppressor genes. I just want to reiterate that these are present in all human DNA, male and female. For somebody who carries the problem for breast cancers and for ovarian cancers is when you have a mutation of the gene, okay? So when there's a mutation of the gene, either BRCA1 or BRCA2, that's when we have individuals at greater risk to develop breast or ovarian cancer. Now, BRCA mutations are present in a variety of different cancers. You do not need to memorize a laundry list of cancers associated, which ones belong to BRCA1, which ones belong to BRCA2. You simply need to know for our purposes that somebody who's BRCA1 in particular positive is going to have some challenges treatment-wise. It's a little more challenging. We're going to talk about some targeted therapies and chemotherapy later on. The BRCA test can be blood or saliva. That is genetic testing. That is typically done at Yale as an outpatient. You can have genetic testing. Again, that is blood or saliva. And people can make decisions about what they want to do. If your BRCA gene comes back as a mutation and you have a greater risk than the general population to develop a breast cancer, it's a very personal decision, but some people do choose to have prophylactic mastectomy, as Angelina Jolie did. All right, so that's a genetic. The HER2 that we talked about, that is a protein found on breast tissue. It's involved in normal cell growth. If it's HER2 positive, it means they're overexpressing the gene. And again, we're going to manage that with targeted therapies that I'll talk about in a little bit. And this is also, the HER2 is done by tissue sample. It can be done with blood work, but the blood work is not nearly as accurate as the tissue sample. So the tissue sample is the preferred method. Okay, so we talked about lymphedema, and let me sort of pick up there. Do you recall who is at greater risk for lymphedema? Is it an individual who's had a sentinel lymph node dissection or an axillary? Axillary, right on. You're taking more lymph nodes, right? So the sentinel, we're taking 1 to 4 lymph nodes. If the sentinel comes back positive, then they're going to proceed with the axillary node dissection. So yes, the axillary, you can get lymphedema with sentinel lymph node dissection, but it's rare. Almost always with axillary lymph node dissection, there's certainly a greater risk for developing lymphedema. So what do you recall just before we move past the lymphedema? What is the nurse's responsibility post-procedure to reduce the risk for lymphedema? Elevation, be specific. Above the heart, absolutely. Above the heart, you want to elevate above the heart. They're going to actually start doing the finger exercises, flexing and extended in the recovery room. They'll actually start doing that as soon as in the recovery room. They're going to, what do we want to teach them when they go home? What do they want to avoid?
No needle stick, no blood pressure.
So no needle sticks, no blood pressures in that arm. We'll place the sign above the bed. What other general information when they go home in terms of teaching? Does the nurse tell them?
Like put a glove if they're gardening.
Put a glove on if you're gardening. So basically anything you're doing at home, whether it's cleaning the house, whatever you're doing that can cause a risk of injury or a break in that skin integrity, they have to be careful. They have to use caution because they are greater risk for infection. They also need to know what the signs of infection are in that arm, right? So we teach them that as well. Lymphedema, you are, the nurse, going to have to help them with the compression garments after surgery. We usually start with a very simple ACE compression wrap that you're going to have to help them with. There are, in the hospital, the Flowtron boots that you have on your patients who are not mobile, that compression device that squeezes and releases. There's a similar conceptually device for the arm that does the same sort of thing. That is used for patients to reduce the risk for lymphedema. But initially, you're going to just be putting an ACE wrap compression garments on it. All right, so that's lymphedema. We're going to move along. We're going to talk about overview of treatment options. So these are, and we'll talk about each of these individually. We'll begin with lumpectomy, then we'll talk about mastectomy. We'll compare and contrast the two. We'll talk about advantages and disadvantages for each, because it's a lot of decisions for somebody to have to make at a time when they're still trying to internalize the fact that they have cancer to deal with, right? So it's a lot of decisions to make. I want to first say, and I'll say this repeatedly, the survival rates for lumpectomy and mastectomy are the same. And this is based on large-scale research studies done not only in the United States, done in France, in Italy, and other countries too. So the data, the evidence is very solid that survival rates for both is the same. Based on that fact, many women will choose to have the lumpectomy. The lumpectomy is removal of the breast tumor and a rim of normal quote-unquote tissue around it to get clean margins. The cosmetic outcome is very, very good with the lumpectomy. In terms of body image acceptance, the lumpectomy emotionally is a little more palatable for women, right? The mastectomy, they're very personal. Again, a very personal decision. Sometimes you give the information to the woman and you say, listen, the outcomes are the same. Mastectomy is a more involved surgery, but it's your call what you want to do. There are women who will say, you know what, I want the breast off. I want all the tissue gone. I understand survival rates are the same. I understand the mastectomy is more involved, but I want the tissue gone. And certainly we honor that. So it's a very, very personal decision. We'll talk a little bit about chemotherapy and hormone therapy, as well as radiation therapy. All right, so what are some of the contraindications, or what are some reasons someone would not be eligible for a lumpectomy? What I'm going to say to you repeatedly, and what you're going to read in your assigned reading over and over, is that when you have a lumpectomy, it's always a package deal. It's the lumpectomy, the removal of the tumor and a rim of normal tissue, in addition to radiation therapy post-procedure. So the radiation therapy is generally in the neighborhood of 6 weeks, but you're going 5 times a week. And no, you're not there a long time, 5 times a week, but think about that impact on one's life, right? If you're working, you've got responsibilities to your family, to others, to yourself, hopefully, to get yourself well. So it's a big commitment that way. Radiation therapy post-lumpectomy is generally well tolerated.
Is the package deal also applies to mastectomy, or is it just the lumpectomy?
No, it applies exclusively to lumpectomy.
Okay.
Yeah. The tumor size here, so when can you not have a lumpectomy? It is dependent on the tumor size. So we do it for smaller tumors. We think about breast to tumor ratio. And so what I mean by that, if a woman has very small breasts and the tumor is large, you're not going to get a good cosmetic outcome removing that tumor. So they may instead opt for a mastectomy with reconstruction. Again, lots of things to consider, a very personal choice. Cancers that involve the nipple are not appropriate for lumpectomy. If there's multifocal, multiple masses, again, not appropriate for lumpectomy. If the individual, this one's big, if the person had prior radiation to the chest wall, as in when they were treated for a childhood cancer and they had radiation therapy to that chest wall, that's a one-shot deal. We don't go back and radiate the chest wall again. So they would be then ineligible for the lumpectomy. The morbidly obese, weirdly enough, for radiation tables, most of them do have weight limits. The slide is 300 to 350 pounds. I know there are tables that go up to 400 pounds. I don't know that there's tables that go beyond that, but that is a consideration. And then it is not generally advised for genetically predisposed to cancers. Again, the surgery is to conserve breast tissue. It's to have a good cosmetic outcome. One of the problems, if you will, that we have with the surgery is, how they have to get that clean margin, that rim of normal tissue around where the breast tumor is. Remember last class I told you breast cancer is not, the edges of it are not round and smooth and perfect, right? That's more like a cyst that's benign. cancer is, and it's ugly in every conceivable way. It's ugly, it's very asymmetrical. It looks more like a starfish. It's got tentacles. It's not evenly shaped. It has very irregular borders. And so it's sometimes difficult for the breast surgeon to get the clean margins. Unfortunately, we don't know it until a week later. It takes a week to get the pathology report back, and sometimes the path report comes back and says we don't have clean margins, and then the poor patient has to go back to the OR again. It's not easy for me to say it's physically taxing. The problem obviously is emotional. To gear yourself up emotionally to go back to the OR again. They do typically get clean margins on the second go around. This happens in about 10 to 20% of the cases. So that obviously would be a disadvantage. And then chemo, whether or not they get chemo is going to be dependent upon cell differentiation. Important concept, what do you remember about cell differentiation? There's two types.
If it's well defined,
There's well, yeah.
And poorly defined is leads to a poor
Right, so there's well differentiated, right? It looks a lot like the parent
regular
cell,
cell.
and then poorly differentiated looks nothing like the parent cell, right? And if it's poorly differentiated, the individual is most likely going to get
has a poor
chemo.
prognosis. Oh, yeah, that one.
I'm sorry, say it again?
I said if it's poor, it has a poorer prognosis, right?
If it's poorly differentiated, it's a poor prognosis.
Right.
Yeah. So if an individual has the triple negative breast cancer that we discussed last class, which is only about 10 to 20% of all cancers, but it is a more aggressive cancer, it tends to grow more rapidly, and it does tend to recur. If a woman has triple negative, the normal order of operation in general is we usually lead with surgery, then do chemo or hormonal therapy, and then radiation therapy is always the end point, right? It's the back of the bus. For someone who is triple negative or has inflammatory breast cancer, that 1%, that very rare and aggressive type of cancer, the order of treatment is going to be different for them. They're going to start with chemo first, and then they're going to have their surgery, and then they're going to have their additional treatments, always ending with radiation therapy. Okay? Oops. I think I didn't have it. Nope, didn't. Okay. So, sorry. Back to
Professor,
yes.
for the last slide you were at, you said start with surgery, then chemo, then radiation.
For the general population, for people who don't have triple negative, you start with surgery, and then chemo and or hormonal therapies, and end with radiation. That's correct. The only exceptions to that rule, Robert, are the triple negative and the 1% with inflammatory breast cancer. All right, so what slide, guys? Am I slide ahead? I feel like I'm slide ahead. This is where we are. Okay. So early stage breast cancers, again, these are candidates for the lumpectomy and breast conservation therapy. Small incision, this is generally done same day. Most of these individuals will go home the same day of the procedure. There's bruising, swelling, and discomfort that is easily manageable. They are back to work typically within a week, unless you have a job that requires a lot of upper arm kind of strength, like a nurse, basically, right? We're pulling patients on and off stretchers, we're mobilizing patients. So a nurse would be out of work for 2 to 3 weeks. But if you work in an office, you're generally back to your routine within a week. So not a lot of time under anesthesia. It's quick, it's outpatient. Most of them don't even go home with a drain. So again, great cosmetic outcome. The breast contour looks much the same. So again, it's a win-win. The only thing is they do have to go for that follow-up radiation therapy. radiation therapy, well tolerated, generally speaking. Why we do it after lumpectomy? A good analogy that I can give you is, when you clean up your supper dish after dinner, you bring it to the sink, you rinse off all the bits of food, the big bits of food that are on the dish, you then throw it in the dishwasher kind of takes care of the rest, right? The dishwasher has that nice hot water, blast of pressure to get rid of the bits of food left behind. Radiation is the same way. Think about surgery as the first rinse, rinsing that dish in the sink. Surgery is going to get rid of most of that cancer, right? But then the dishwasher is this radiation therapy. It's going to take care of whatever is left behind. So the woman is going to meet with the radiation oncologist. Remember we talked about picking your team. The radiation oncologist is on the team, and the woman is going to meet with the radiation oncologist early on in the game to talk about the treatment plan. Okay, so again, 5 times a week in the neighborhood of 6 weeks. It may be a little more, maybe a little less, depending on the radiation oncologist. In terms of serious complications, because of where it is anatomically, there is a risk for damage to the lung or to the cardiac tissue, very rare. Less than 1% have that issue. Again, it's a one-shot deal. Once the chest wall has been radiated, we don't radiate it again. Lisa Anderson spoke with you about radiation therapy. If the skin is bothersome to the individual, the radiation oncologist will prescribe various ointments or topical agents to help with some of that discomfort. The radiation oncologist is going to tell the person not to use anything over the counter. They will prescribe whatever topical agents may be needed. The skin, of course, may peel like a sunburn does, but overall, it's generally well tolerated. I'd say the biggest side effect that patients complain of is the fatigue. So it is overwhelming. It is a conversation that you have to have with your boss and your family members, because you're not going to have the energy to do some of the tasks you were able to do pre-radiation therapy. You will recover your normal energy levels after you complete the treatment. All right, so mastectomy is more involved. So a mastectomy is removal of the breast tissue, nipple and nodes, and this is definitely an overnight procedure. They're in the hospital for a day or two, and most women tolerate the mastectomy fairly well. The breast plastic surgeon and the breast surgeon will be in the OR together. The breast oncology surgeon will be removing the breast tissue, nipple and nodes, and the plastic surgeon will then begin working on the reconstruction at the same time. They will place something called a saline expander, and what that is just what it says it is. It's a pouch, if you will, a plastic pouch filled with saline, and the plastic surgeon can add more saline to it, and it'll be in place for a few weeks. So they can add additional saline to it in the office. The purpose of the expanders is to stretch the remaining skin left behind so that it will accommodate an implant. And then generally 3 weeks or so afterwards, they'll go back, the plastic surgeon will take out the expander and replace it with the implant. So there is a second procedure involved, which makes this a bit of a disadvantage, right? You have to have a second procedure, and then if you want nipple reconstruction, that may be even a third procedure. Granted, the second procedure is just switching out, again, taking out the expander and putting in the implant. It's not nearly as involved as the original surgery. Yes?
Hypothetically, if the woman didn't want implants after, would she need the saline expander? Or
The saline expanders are not meant for long term. I don't think we have a lot of good studies that leave them in place. If she doesn't want a silicone, do you mean? Because she can get a saline implant, which is softer and the contour is better. It's better cosmetic outcome.
There's some breast cancer survivors that kind of just.
If they don't want anything,
Yeah.
I'm sorry. They don't have to have anything.
Yeah.
They can just use an external prosthetic.
Yeah.
That's very realistic looking, and you get a special bra, and it fits into the bra.
And so-
It's swimwear and tops and everything
In
else.
that case, they wouldn't need the saline expander to stretch the skin.
Correct. If they're not choosing to have reconstruction, they would not need to have that skin stretched. I'm sorry. Yeah, that's a
okay.
great question.
Yeah, thank you.
Yeah. Yeah.
You said the reconstruction is
It definitely is mandated covered by insurance. It is a law, so make sure your patients know that. And Medicare and Medicaid has to cover it as well. And they cover surgical interventions to the remaining breast so that it matches the newly reconstructed breast. And a lot of people don't know that. There was a research study done on lower income, less educated women, and they had much significantly lower rates of reconstruction because I don't think anyone made them aware of the law. So that is your role as nurses, to advocate for your more vulnerable patient populations. Make them aware it's a law. Insurance and Medicare and Medicaid have to pay for the reconstruction. Great point. Okay, so mastectomy definitely more involved. They are going to come out of surgery with drains. Drains are that like long rubber tube. It's got perforations in them. It's made through a small incision in the skin. It's attached to a bulb. I'll show you what the drain looks like on an upcoming slide. We teach them how to empty their drains, how to measure the drainage. We want them to know what the drainage should look like. If there should never be an odor to it. If there's an odor to it, they need to notify the provider right away. The drains are in place most commonly for 1 to 2 weeks, but can be in place for up to 3. We don't like to leave them in place for 3 weeks because it increases the risk for infection. But how the surgeon decides when to pull the drain, and they pull the drain in the office, but they make the decision based on the amount of drainage that the woman is measuring at home. There are garments that are designed for the drains. If you have a bilateral mastectomy, then that's 4 drains. You're typically going home with 2 on each side. So there are garments with pockets in them that they can place their drains into, which is more comfortable for them. There's also through, I think it's the American Cancer Society, you can rent, you know those chairs, you think of them with older people, but they lift you up. It's like a lounge chair or recliner, but it lifts you from a sitting to a standing position. You know what I mean? Those chairs, electric chairs. So the American Cancer Society provides rental of those for women recovering from, particularly with bilateral mastectomy. If you're using your chest muscles to get up out of the chair, right? It's really hard to get in and out of the chair. Okay, so if reconstruction is done, that adds another 2 to 4 hours onto the anesthesia time. Again, they're in the hospital a couple of days. This is a solid 6-week recovery. Now the transverse rectus abdominis, musculocutaneous, the tram flap surgery, this is way, way more involved. This is, but I will say this about this particular procedure, it uses the abdominal muscles and fat tissue from elsewhere on the person's body. So the fat tissue typically is from the abdomen too. So they're using the person's own fat tissue and their muscle to reconstruct the new breast. So for women who don't want an implant, the middle procedure, the one in the middle, is actually a tummy tuck. With breast reconstruction. And this is an option for somebody who doesn't want a saline implant that has to be changed out in 20 years, right? This is another option. It's a great option. It's wonderful. Everybody wants the tummy tuck, right? Everybody's like, I need the one in the middle. So the tummy tuck. It's a great option. Here's the but. There's always a but. The big but here is that you're on the OR table for 6 to 12 hours. This is a really, really involved surgery. The cosmetic outcomes are outstanding, really beautiful. Younger women certainly can tolerate being under anesthesia for 6 to 12 hours, but if you think about some of your older women, that's a long time under anesthesia, right? The recovery, think about the recovery as a nurse. You get this patient coming back to you. It's going to be hard because they're recovering from chest surgery, making incentive spirometry difficult, making getting in and out of a chair and mobilizing difficult, and then they've got major abdominal surgery on top of it. So they're recovering from 2 major surgeries. Their recovery time, remember we said for mastectomy is 6 weeks. For these people, it's closer to 8 weeks. It's a really tough recovery. A lot of women feel it's worth it for them in the end because it's their own tissue. They just feel, it's a great cosmetic outcome. It really, truly is. But it's a tough, tough surgery. Yes?
Same as their own tissue that's going into that same area that you had cancer previously, is that increased patient pain? chances of getting cancer again?
Studies have not shown that because the fat tissue is usually taken from the abdomen or the buttocks, and studies have not indicated, cancer growing out of that subcutaneous tissue. Okay, so that's the transplant procedure, and then there is a thing, the name of the law, you will not be tested on this, but the name of the law, I didn't throw it on the slide, is the Women's Health and Cancer Rights Act. You would not be tested on this by me certainly, or on your NCLEX, but again, just so you can advocate for your patients who are less educated, who apparently are not being told that they have a legal right to reconstruction. So always advocate for the underdog, right? For our vulnerable patient population. So this is what the drain looks like. How many of you have seen this, worked with this, emptied one of these? So a few of you. Okay, a few of you. If you work on a surgical floor, you see these all the time. So it's shaped like a grenade. There's a cap on it. You pop open the cap. You squeeze the contents into, the sterile urine cups we send sterile urine in, the clear containers. They're marked and they have a white screw on top. That's what we empty the drain into, because you can measure it easily. Plus you can see the color of the drainage in that container, and the patient will go home with it. It'll teach them how to empty it too. Once you squeeze the contents of the drain out into the measuring device, you're then going to keep holding that bulb in a flat position and recap it, and then that's going to create the suction to pull excess drainage out. It takes tension off of the suture line. Pain management is the same as pain management for any post-op patient. Again, teach them to look, if they're ready. We don't ever rush somebody to look at their chest wall post-mastectomy until they're ready to do it. Emotionally, it is a big thing, and they need a lot of emotional support. If they're not ready to look at the drain sites, we can teach whoever their primary caretaker is to examine the drain sites for evidence of infection. The color will start bloody initially, then it gets a lighter pink, and then sort of like a light gold, and then it gets clearer as the drain diminishes. It never gets clear though, it's never perfectly clear, no. It's more like serous fluid, like pink. Okay, so lumpectomy advantages and disadvantages, just to recap, great cosmetic outcome, is a huge advantage. They're home and back to their life very quickly, huge advantage. The disadvantages are they do have to, it's a package deal. They've got to go for several weeks of radiation therapy, and they've got to go every day. That's a big commitment. There is a slight risk for return of cancer in the remaining tissue in that breast. It's less than 5%, but certainly that is a disadvantage. Mastectomy can happen with mastectomy, very rare. It happens in less than 1 to 2%. Sometimes a minuscule amount of breast tissue is left behind, and the cancer can recur there. But again, very rare. Does not change the fact that survival rates are still exactly the same for both lumpectomy and mastectomy. Okay? They still obviously would have to go for mammograms, which is emotionally very hard for them, given what they've been through. And, again, zero difference in survival rates. Please change your slide, depending on when you printed this. It may be right on your PowerPoint, but where it's highlighted, it should look like this slide. So on the left, it should be disadvantages. On the right, it should be advantages. I had a typo that I realized afterwards. So depending on when you printed your PowerPoint, it may be incorrect, it may be reversed. So your PowerPoint should look like this. Is the point. If it doesn't, fix it. Okay, so disadvantages for mastectomy. There is more disfigurement. Even with very talented plastic surgery, the outcomes are not as nice as somebody with a lumpectomy in terms of the contour and the shape. It is definitely a longer anesthesia time. It's a day or two in the hospital, bless you. And again, expanders are placed at time of surgery. The advantages rather, lower risk for return of the cancer. They don't have to go for follow-up mammography. However, if they have, that's for bilateral, if they have a breast remaining, they still have to have follow-up mammography on that remaining breast. They don't get radiation, and the bulk of their reconstruction is done with that initial surgery. but they have to go back. They have to go back for the swap out of the implants, the removal of the saline expanders and the placement of the implant, and then if they want nipple reconstruction, that's entirely up to them. They would go back for a procedure for that. After the nipple reconstruction, there are extremely talented tattoo artists. Some of them even donate their time, they don't even take money for it, and they do 3D nipple tattooing that is so realistic looking. Again, just an option to make your patients aware of. All about body image, right? All right, so we're going to talk a little bit about estrogen and progesterone receptor status. Yes?
Earlier when you said that lumpectomies are not advised for genetically predisposed cancers, is that as far as like if you have a first degree relative with?
Yes.
Okay.
That's the BRCA, that's the genetic predisposition. Yep. So her question was why it's not, the lumpectomy is not recommended for somebody with a genetically predisposed cancer. It is somebody with BRCA, a family history, first degree relative of breast or ovarian cancer.
Okay, thank you.
Yep. They would do a mastectomy. They recommend a mastectomy. They would, yes, if they want the genetic testing, yes, they would do that. Not everybody wants the genetic testing. Right, right. All right, so estrogen receptor positive. These tumors respond nicely to hormone therapy. We're going to talk about in a minute tamoxifen and AI. These cells tend to be well differentiated. I know we keep saying this well differentiated. That's what it looks like under the microscope. But again, these are prognostically good. They respond well to treatment. Risk for recurrence is low. And again, they do very well with tamoxifen and aromatase inhibitors. The receptor negative tumors, these, not the same story. These do tend to grow more rapidly. These tend to be more aggressive overall, and they do tend to recur. And that is why people, again, I'm going to just say it again, with triple negative, have to have the chemo first, really hit those cancer cells hard, then the surgery, and then the radiation therapy. Hormonally, somebody who's hormone receptor negative is not going to respond to tamoxifen. Their tumor is not fed by estrogen or progesterone, all right? So they would be, tamoxifen would be inappropriate for these individuals. All right, so HER2, genetic mutation, again, that promotes cancer cell growth. This is not genetic. HER2 positive is a little trickier for us to manage. Again, higher rates for rapid spread, tends to be more aggressive. Cells tend to be poorly differentiated. So it's a little more aggressive, prognostically not as good an outcome. However, I will say we now have targeted therapies that respond, HER2 positive responds very well to. So there is always hope. Again, that would be Herceptin and Perjeta primarily. I'm sorry, you're asking me about the meds, but I can't hear the second part of what you're saying. Lifelong treatment. That would depend on the medical oncologist. Okay, so other complications. The post-breast therapy pain syndrome, it's pretty rare. Don't go down this rabbit hole in terms of budgeting your time for study. It's pretty rare that women develop this. Know that there is such a thing. And it really develops into a chronic pain syndrome that we treat the way we treat all chronic pain. There is actually phantom breast pain. Remember we talked about phantom pain in the fall. It can occur anywhere. You can have phantom pain if you have a finger amputated or a toe, right? It doesn't necessarily matter the amount of tissue. In this case, it's the breast. It's very unsettling, as you would imagine, for a woman whose breast has been removed to then have that feeling or sensation that it's there. The pain can range from mild to debilitating, and we would treat it typically, because it's neuropathic pain, we would treat it with gabapentin or Neurontin. That is really the drug of choice. We can use other agents as well, yes, for the pain.
No, I have a quick question about the HER2. I'm sorry.
That's okay.
So I know you said with the ER positive, that's a low risk of reoccurrence. So on this slide, so the positive with the HER2 is a greater risk of reoccurrence?
The person can be,
If they're HER2 positive,
if they're HER2 positive, yes, it's a greater chance.
it's a greater
of
chance.
recurrence.
Okay. I just
Yes.
wanted to make sure I was reading that
Yep,
right.
you got
Okay.
it.
All right. Thank you.
Yep. All right, so chronic pain, again, don't see it that commonly, thank goodness. They have enough to deal with. In terms of recurrence, it can be local to the skin or chest wall. It can be regional to those lymph nodes. Lymph nodes most commonly are the axillary lymph nodes, but it can spread to clavicle lymph nodes as well. There can be distant metastasis, think LLBB most commonly, liver, lung, bone, and brain. Neoadjuvant therapy, this is add-on therapy. An example of neoadjuvant therapy is when we lead with chemotherapy, when we do chemotherapy before surgery. So we're doing something to shrink the tumor prior to taking them to the operating room. And again, the patient population, most commonly we're going to do that for is our triple negative individuals and that inflammatory breast disease. They're going to have chemo first before surgery. Yes, Jane?
Triple negative is same as HER2 negative, or is that different?
It's triple negative is hormone receptor negative, progesterone, estrogen, and HER2 negative.
Okay.
Yep. So they're going to get, the triple negative individual is going to get the chemo first. Then the surgery, radiation is always last in line. Inflammatory breast is the same. There's one other exception, is if somebody has, remember we talked about lumpectomy, it depends on the tumor size. If the tumor is too large, they may not qualify for a lumpectomy. You have to think about breast and tumor size ratios. So sometimes they will shrink. If a woman's tumor is like on the fence, it's a little bigger than they would prefer for a lumpectomy, they may use, the oncologist may say, listen, let's do a little bit of chemo, shrink that tumor a little bit so that you will qualify then for the lumpectomy. A combination of meds are used for better outcomes. No, generally with chemo, we're going to use a combination of agents because we want to hit that cancer cell. And remember the life cycle of the cancer cell. We want to hit it in all of its developmental stages. We want to get the most cancer cell kill. The duration of chemotherapy is generally 3 to 6 months or 4 to 6 months in that neighborhood. Side effects, remember, cancer cells are rapidly reproducing. And so those are the cells chemo targets and kills, but it can't differentiate the toxic cancer rapidly reproducing cells from the normal healthy rapidly reproducing cells. So our normal healthy rapidly reproducing cells line our GI tract from lips to anus. So when you think about side effects, think of it that way, and the hair follicles. Okay? So side effects, nausea, vomiting, diarrhea, bless you. Certainly anemias, chemo tends to suppress the bone marrow, so we will give colony stimulators, Elastin and Epigen, to increase the red and white blood cell count respectively. Nursing management centers mostly around teaching and managing side effects associated with chemo.
It says lifetime treatment for chemo with metastasis, but I don't think they don't have a certain amount of chemo before they're like cracked off.
That would, again, that's the oncologist's call. So it depends on the stage, whether or not somebody has it like one, that would be the oncologist's call. Okay, so hormonal treatments. This is tamoxifen and aromatase inhibitors. Yes?
Can you repeat that normal rapidly reproducing cells? I think
Yes.
you said something, I want to hear it.
Yeah. So chemotherapy cannot, it's good, but it can't differentiate. Cancer cells are rapidly reproducing, okay? So chemo can't differentiate the cancer rapidly reproducing cells from the normal body's rapidly reproducing cells. So the normal, healthy, rapidly reproducing cells in our body are the cells that line our entire GI tract from the lips to the anus, and it's also the hair follicles. And so when you think about side effects of chemo, it's going to cause the hair to fall out, and that is why. Does that make sense?
Yes, thank you.
Okay, no problem. Okay, so hormone therapies such as tamoxifen reduce the risk of mets by killing cancer cells out in circulation. Typically, the woman will take 1 pill a day for 5 to 10 years. If, again, it's a triple negative breast cancer, then we are not going to use hormone therapy. It is not a hormonally fueled cancer, so it would be inappropriate for that patient population. You can use it in pre- or postmenopausal women. We use it most commonly in premenopausal women. But I will say this, premenopause, young women, women of childbearing years, tamoxifen is very toxic to a developing fetus. So the woman has to have a reliable form of birth control if she's going to take tamoxifen therapy. The recent research indicates that a 10-year course is more appropriate for premenopausal women.
What's AIS?
Hmm?
What's AIS?
Oh, aromatase inhibitors. I'm sorry, it's on the next slide.
Okay.
Sorry about that. And then no added benefits for DCIS, I abbreviated there. That's ductal carcinoma in situ. Anybody remember what that was?
Oh, it's not a
Sitting in place, it's an easy one to manage. There's no benefit to add-on therapies, 98 to 99% cure rates, right? We don't get to pick one, but if we had to, that would definitely be the one we would pick. All right, bless you. Hormone therapies. So estrogen receptor blockers. These block the receptor sites for hormonally fueled cancers and estrogen-positive cancers. Tamoxifen has been around since the 70s. It's a good drug. It's effective. It does the trick. Again, not in premenopausal women, they have to be on reliable birth control. In the under side effects, if you look at this first line, the most common side effects with tamoxifen are generally like menopause kind of symptoms, like hot flashes, vaginal dryness, nighttime sweats, those kind of things. We expect that and we warn the patient about that. That is pretty normal. What's not normal is their risk for DVT or PE or stroke. Obviously, those are adverse more than adverse side effects. We don't expect those, but we need to, teach the patient about side effects of those. Visual changes, always tell your patient to call the healthcare provider right away with any visual changes. It can cause irreversible retinopathy. Okay. Rarely endometrial cancer, but because pre- and postmenopausal women can use tamoxifen. If you're postmenopausal, you haven't had a period in years, you start out on your tamoxifen therapy, and all of a sudden you start having spotting or bleeding. Again, as the nurse, we have to teach them they need to notify the healthcare provider. That is not normal, that is not expected, and again, can be a risk for endometrial cancer. The aromatase inhibitors, this is the AIs, Armidex and Femoral, this is given generally for postmenopausal women primarily. The side effects here are osteoporosis, so this patient is going to start with a DEXA scan. We're going to get a baseline of their bone health and then periodically monitor their bone health as well. There's estrogen receptor modulators, raloxifene or Evista, and Megase. These prevent osteoporosis, so they serve a dual effect, which makes them a nice choice as well. And then the biologic targeted therapy, certainly appropriate for hormone-positive breast cancers, also appropriate for HER2-positive breast cancers. In fact, remember, HER2-positive is that more aggressive, poorly differentiated cells, higher risk for recurrence, but they do, as aggressive and nasty as HER2-positive can be, they respond very well to biologic targeted therapies, specifically Herceptin and Perjeta. Side effects here are not delightful. They are cardiac, so we need to teach them about signs and symptoms of heart failure, when to notify the healthcare provider. If they're feeling any palpitations, if they're feeling as though they're short of breath, if they're noticing fluid in their legs, and signs and symptoms of heart failure or cardiac anomalies, they need to report that to their provider immediately.
Did you say it's usually a combination therapy of multiple of these, or?
It's more this, it's more the combo with the chemo. And that's for any cancer. That's a general rule of cancer therapy, is we hit them with multiple different types of chemo at different times. And it's to get that, to hit at various stages of the cell cycle, the cancer cell cycle. So the common ones we use are Cytoxin, Can be used for lots of different cancers, but it is indeed used for breast cancer, generally well tolerated. One of the things, if you're the nurse administering the Cytoxan, if you're the nurse, period, you have to be chemo certified. So you do have to have additional training. You can't just walk into a center and take chemo. And if anyone tells you you can, they're wrong. Say no. You have to have additional training. You sit for testing. You get certified. So please don't ever, somebody hands you a bag of chemo and tells you to hang it. Don't do it. Don't do it. Don't do it. Chemo is mixed by a PharmD, a doctorally prepared pharmacist. RNs, 2 RNs, double check the dose. It's weight based. It's potentially, it's meant to be toxic to cancer cells because chemo can have an adverse effect on fetuses. If you are of childbearing years, handling chemo, hanging chemo, you wear an apron. I think Lisa Anderson probably talked with you about that. But that's the standard of care. You wear an apron to protect yourself. So Cytoxan, generally well tolerated. One of the things you may see as a nurse with Cytoxan is their urine may be a little pink or red because it is a bladder irritant. Methotrexate is not first line, but is used less commonly now than it used to be, but it is another alternative. Again, generally that one is well tolerated as well. The 5-FU is used for lots of different cancers. Again, this is a pretty powerful chemo drug, not the most powerful chemo drug on the slide, certainly. Most people do pretty well with it. The side effects are here on the bottom. People will complain of taste changes. They get like a metallic taste in their mouth. It's usually while the infusion is running, okay? And that's pretty common, that's expected. The star of the show here, if you will, is the adriamycin, or the doxorubicin. We call it the red devil. There's a little red devil next to it. We call it the red devil because it's red in color. And it is a heavy hitter. It's like, one of the strongest chemo agents we've got to hit this breast cancer hard. Why it's the star of the show is because it hits that cancer cell cycle at every single stage of the cell cycle. So it has what we call high kill rates, high cancer cell kill rates. That said, unfortunately, there are can be toxic to the heart. So there are cardiac side effects that we have to assess our patients for and teach them what to assess for at home. Things like we just talked about. If you're developing fluid in your feet, you're noticing fluid in your feet or your lower extremities, if you're having shortness of breath, if you're having palpitations, anything unusual, they need to notify the healthcare provider. Cytoxan we talked about, and then Taxol and Taxotere. These tend to have neuropathy side effects in the hands and or feet that usually are dose related. The chemotherapy is generally a few hours per session. It's given in cycles, again in the neighborhood of 4 to 6 months. They get a treatment, a total of 6 to 8 cycles. There's 2 to 3 weeks recovery time in between, and again, it's a big commitment of time. It's 4 to 6 months. HER2 negative, again, HER2 positive. HER2 positive is very responsive to chemotherapy, even though it's aggressive. And triple negative need chemotherapy as well, as we've said repeatedly. Hair loss is the most distressing of the side effects associated with chemo for women. That's not about vanity. That's about, we all have trouble with that, right? That's a big adjustment for us. There is a cap. It's called a cold cap. You won't be tested on this. You don't need to write this, but if a patient asks you about it, I want you to be able to respond to them. So there is a cold cap. Not every cancer treatment center has it, number one, that's available. It's not yet FDA approved, so that's a problem. And insurance doesn't cover it. So what it looks like, the intention of it is to basically reduce the risk for hair loss, right? So it looks like a swimmer's cap, like a space-age swimmer's cap. It has all these little rubber tubings in it. It attaches to a machine. The machine pumps in ice cold water to the scalp. If you've ever eaten ice cream, you know how you get brain freeze? Like you eat something cold really fast and you get that brain freeze. This is like brain freeze on steroids. So not everybody can tolerate it. It's really uncomfortable for a lot of people. If you can tolerate it, it may reduce your risk for hair loss. I will tell you that it's attractive in a lot of ways to even just try. However, there are oncologists who strongly feel that more randomized studies are needed before they will recommend this to women. And the reason is, and I trust my oncology colleagues, they are experts in how stealthy cancer cells can be. So their concern is what you're creating by making that scalp cold is you're preventing the chemo really from getting to those hair follicles, right? You're creating this barrier, if you will. So the chemo is not getting to the hair follicles, and that's what reduces your risk for losing hair. It doesn't work for everyone either. Some people lose their hair anyways. The oncologist worries about some stealthy, tricky, sneaky cancer cells making their way up to that chemo-free zone, if you will, and taking up shop there. So that is their concern. And again, they know way more than any of us ever will about how stealthy cancer cells are. So I would err on the side probably of let's wait for more randomized clinical trials before you make a recommendation to a loved one, to a family, or to a friend. Because you will be asked as nurses about the cold cap. I would talk with them about wigs, I would talk with them about scarves and other options to deal with the hair loss. The nausea, constipation, diarrhea, we know we're going to use Zofran IV for the nausea. We'll treat constipation and diarrhea the way we always do. For the anemias, chemo suppresses the bone marrow, so we'll treat it with colony-stimulating factors, the Neulasta and Epigen to stimulate the white blood cell count and red blood cell count, respectively. Neuropathies will treat with Neurontin or gabapentin. Appetite and taste changes. We try to pick things that are nutritionally valued. We try to give them higher protein things if we can, if they tolerated them. And then a lot of side effects of chemo are functional menopause, and so we need to prepare them for that as well. Okay, alternative and complementary therapies. We talked about this in the fall. Again, don't go down the rabbit hole in terms of budgeting and time for studying. But again, as nurses, you'll be asked by patients, listen, I don't want to go through this chemo. I don't want to put myself through it. I have a family member that went through it. It was terrible. I just don't want to do it. I'm going to do this homeopathic thing instead of Western therapy. Western medicine, imperfect as it may be, is still scientifically proven to enhance and improve survival rates. So I could not, in good conscience, as a nurse, we are scientists, right? We're loyal to our science. I could not, in good conscience, recommend a patient use an alternative therapy or complementary therapy in place of traditional Western medicine. They can use it in addition to, and that's encouraged, certainly. If you're working with an herbalist, all we ask is that the herbalist and oncologist connect with each other, because some of the herbal remedies can be liver toxic, particularly if you combine them with chemo. So we just want for the herbalist and the oncologist to work with one another. Vitamin D deficiency has been shown to increase risk for breast cancer, so all women are routinely checked for that now and given supplemental therapy if they are deficient. So younger women, in terms of lifespan considerations, again, cancers tend to be more aggressive, particularly if you've got a genetically predisposed cancer. We talked about radiation therapy through chest wall. If you had it in childhood, that does increase your risk for breast cancer in adulthood. It's like you treat and save one cancer, but then predispose somebody to another form of cancer. Again, changes in the BRCA with close relatives is a decision women have to make if they want to do prophylactic therapy. That's a decision they have to make with their healthcare provider.
So we would say the highest risk is if you have a close relative, is that what you're saying?
That is, yep, first degree relative with a breast region, particularly if it was premenopausal too. Dense breast tissue, remember that's the one we talked about. It's like trying to find a polar bear in a snowstorm. So women with dense breast tissue are going to need closer follow-up. They're going to typically have the mammo plus the ultrasound. Breast cancer in pregnancy, thankfully, is rare. 1 in 3,000 pregnancy, thank God, is rare. But it happens, and when it happens, you have to deal with what's in front of you, right? So it happens in the first trimester, you know, you're looking at 40 weeks, particularly if it's hormone positive, which the majority of them are, 60 to 70% are hormone positive. So if it's hormone positive, estrogen and progesterone are going to fuel that tumor, right? So if you're pregnant, obviously you're going to have very high rates and increasingly high rates of estrogen and progesterone. So it's like hay on fire. A woman does have options. They are presented to the individual. One of the options is termination of the pregnancy, and some women do opt for it if they live in a state where that is legal. And it's a very personal decision. It is not always obviously congruent with individuals' religious beliefs either, but it is an option.
So within a state that it's not legal, we're saying that they allow the pregnancy to continue?
Correct.
That's crazy.
So, so in the first trimester, again, there's some options, and it is a woman's choice to continue the pregnancy. In the second trimester, if you're diagnosed in the second trimester, the pregnancy is too far advanced. Termination of the pregnancy is no longer an option, not legally, morally, ethically. It's not an option. And so typically surgery has been done. They will have the high-risk obstetrician will be in the operating room with the oncology breast surgeon, with the plastic surgeon. So they will do surgery, have done surgery in the second trimester. We can't start tamoxifen because it's so dangerous to the fetus. In the third trimester, if it's at 35 weeks, we can deliver the fetus safely at 35 weeks and then continue on with the therapy. The consult with an oncofertility specialist for egg harvesting and freezing is recommended for women in these situations. Insurance does not cover the cost, and it is very, very expensive. A drug called Zoladex can be given. It basically puts the ovaries to sleep while the individual is undergoing treatment. In terms of lifespan considerations, older patients, if they're diagnosed, you know, say 90 years old, they're diagnosed, it's really up to the patient and their family, and they will consult with their healthcare provider in terms of how aggressive they want to be with reconstruction. There are very spunky 80 and 90-year-olds. Some of you have taken care of them in the hospital, right? And they're still driving, they're still very involved in their community, and they want everything done, and we honor that too. Conversely, you have people who are older with multiple comorbidities who, you know, you would not encourage to have extensive anesthesia time for some of the reconstructive options. So in terms of the nursing process, you know, obviously from the time the person is diagnosed and has to take it in emotionally, has to pick their team, make all of those huge decisions. The person then gets through their therapy. You as the nurse are there every step of the way. And women most often expect to feel a tremendous sense of relief and gratitude when the therapy is done. And that is not always the way it plays out. Sometimes they now have to adjust to their new normal, right? They're relieved, they're grateful that the therapy is over, but now they have to adjust to their new normal and worrying about the cancer reoccurring. I'm not going to read this to you. I can read nursing problems. What are some nursing problems?
Body image.
Body image for sure. Think about the surgical interventions along with body image. Infection, yeah, infection.
Cellular regulation.
Say it again.
Cellular regulation.
Is the concept altered cellular regulation? Yep, correct.
Pain.
What are other problems? Think about the chemo. Pain, post-op pain. Chemo, what about chemo? Infection, yep. Anemias, radiation, fatigue. Tissue integrity. Good. All right, this I'm not going to read to you. This is pretty straightforward, as is this. I'll just say in terms of follow-up, when all is said and done, the patient will be seen by the oncologist every 3 to 4 months after the treatment has completed, then twice a year, then once a year.
I've noticed, and I may have missed it, and we may have covered it previously, but within the cancer material, we haven't talked about marijuana at all. And I think think that's something that a lot of patients are going to ask about. And so I'm not sure if that's going to be covered at any time. But it might be something that we would want to know answers about. I feel like I have a pretty good idea of what it does and how it helps, but
Right, now that's.
having like a specific knowledge would be good, I think.
Right. All right, I'm going to take 5 to a 5-minute stretch, and then we'll finish up. Yes, James?
It's still nice.
Slides rapidly.
Did you submit your clue already? How many concepts did you do? 3. She said she wants to talk to me about mine. Did she say that for you too?
You only did 2?
No, I did 3 concepts, but she was like, oh, we gotta talk about it before you submit it. I assume maybe it's because she didn't want me to do 3 concepts, but like, the rule says we have to do 3. So I don't know.
I didn't even ask you really about my concept.
Yeah, me either. I figured it would be fine because I've done so
So,
many before.
Yeah.
we're going to talk about chronic pain, this is as it relates to cancer pain.
It's under, no, go back one. It's under here, yeah. Did you hear it's supposed to snow tonight?
I know. I wonder if we're gonna have a little bit tomorrow.
Yeah. I wonder if we're gonna do like a online joint post conference.
Oh, tomorrow we have to do that thing, right?
Yeah, I brought all the papers because I got more info than we needed, but people were like, oh, it's fine with what we have. I think it's tomorrow, right?
He might need to. That's
I think so. And then on Wednesday we have a test at ETI, I think. I don't know if it's ATI or whatever it is, but they're letting us out an hour early.
We have to come back here.
I think we just do it online, like at home or wherever.
And that's when I gotta look at it.
Oh, it's the NCLEX practice test, whatever it is. So much stuff.
There are certain cancers associated with more pain than others. You are not to memorize this laundry list. It's really there for your reference, but there are certain types of cancers associated with higher levels of pain. Pain can be acute and or chronic, as we know. Cancer pain, in terms of where it falls on the continuum, it falls under chronic pain. So our focus is going to be on giving them long-acting opioids with some immediate release or breakthrough. There's different types of cancer pain: visceral or nociceptive, which is poorly localized and deep. This is like organ pain, encapsulated tumors, like we see with renal carcinomas. There's neuropathic pain. This tends to be burning and very uncomfortable. We treat it again with gabapentin. And somatic or nociceptive pain is localized, more aching and throbbing. It's more muscular and soft tissue in nature. This is strictly for reference. You have already learned this. You've already been tested on this. Just for our purposes, relative to cancer pain, our focus is more on the steps 3 and 4. We're bringing in the big guns to manage chronic cancer pain. We consider the unique needs of the patient. If they've got pre-existing pain issues, somebody who has a comorbid condition of fibromyalgia, they're not going to be opioid, what we call opioid naive, right? They have been on opioids to manage their either the rheumatoid arthritis or their fibromyalgia. So that simply means we're going to have to give them higher doses of opioid to manage the cancer pain. History of drug abuse, I've said it before, and I'll say it again, and the literature supports this. If somebody has cancer and they have a history of drug abuse, we do not deny them opioid pain management. We treat their pain as we would treat and manage anyone's pain. The dying patient, it goes without saying, their pain is managed, and that is the #1 priority for us as healthcare providers. So the causes of pain can be direct tumor pain. The tumor, as it increases in size, puts pressure on the nerve endings. It's the nerve endings that send the message to the brain, the sensation of pain. So technically, if we can reduce the tumor size, either by surgically excising or removing the tumor or shrinking it with chemo, that then takes the pressure off the nerve endings and gives you relief of pain. The toxic effects of cancer therapies certainly are not easy, and then of course psychological stress as well. So independent interventions, adjuvant, we give analgesics a helping hand. These do not replace the need in cancer pain. For opioid, we always lead with pharmacotherapy, but these help it work better. And these are all things we talked about in the fall: massage, acupuncture, etc. The collaborative interventions, again, we're focusing more on the step 3 and 4. So we're using primarily morphines, opioids, typically long-acting morphine with immediate release morphine for breakthrough pain. There's a couple of different forms of morphine. Cadian is one form that's nice for somebody who has difficulty swallowing. This is somebody who maybe has a head or neck cancer or esophageal cancer. If swallowing is difficult for any reason for the patient, this form of morphine comes in a capsule. In that capsule, it's filled with tiny little beads or pellets. You can open up that capsule, you can sprinkle it on applesauce or pudding for them to physically get the medicine in. However, they still can't crunch or chew on those little beads, those little pellets. But it is an option for somebody who has difficulty swallowing. What you're going to see as a nurse in your practice is MS content is given most commonly. There's no ceiling effect, meaning we can give higher and higher doses to achieve a therapeutic effect. So this one cannot be crushed or chewed on. It is long-acting. And again, because this cancer pain, it has this background 24/7 pain, they're going to have the MS content for that background pain and then the immediate release morphine for the breakthrough pain. Morphine does interact with a variety of agents listed here on the slide for you. And the patient needs to be aware of that. The transdermal patch, the Duragesic patch, is, again, long-acting. It's a nice choice. They don't have to swallow anything. It's a patch you put on. It's on for 3 days, 72 hours. If you're the nurse putting it on, put a pair of gloves on to apply it. You're putting it on in much the way you would put a Band-Aid on someone. You're removing the backing and applying it. You want to put it on a flat area of the skin that doesn't have a lot of hair. You don't want to put it in an area of the body where there's moisture and it will fall off easily. You don't want to put it on scar tissue where it's not going to absorb properly. You want to avoid putting it on skin that's irritated in any way. So when you apply it, again, gloves on, you apply it, you remove the backing, you apply it, then take the palm of your hand, you hold it over the patch for 30 seconds to make sure that the patch adheres well. Patients are told when they go home, if the patch falls off at home, they're to apply the new one, discard the old and apply a new. And we pretty much do the same thing in the hospital. But in the hospital, because it is an opioid, it's a controlled substance, there's a special container in our med rooms that we dispose of that old patch that has fallen off. Okay, or if we're just switching the patch in 72 hours, we're discarding the old one and putting a new one on. There's a special container in the bedroom where you discard opioid patches. Very effective treatment, generally well tolerated, and does the job. Okay. That's all I want to say about that. Constipation is, these are not new to you, right? Constipation, you know, bless you, is a problem with opioids, so they should be on a bowel routine, they should be on Marilax. Certainly you can give them Dupalox, you can give them enemas if it comes down to it. Increase fiber in the diet, encourage the increased fluids, all of those kinds of things. We would treat itching should they develop it with antihistamines and lotions, and of course nausea and vomiting with IV Zotran. So if an individual is on MS content at home and they're using their breakthrough med more frequently than we like, then obviously that's a fault of the healthcare provider because their MS content dose is not high enough. So we need to get the dose adjusted. Intrathecal pumps for cancer pain. Don't go down this rabbit hole, I'm just mentioning it. It is an option, but it's not an option for many because it's very expensive. Insurance doesn't always cover it, but it is a way of getting pain management in somebody who has intractable pain where nothing else has worked for them. So the potential risks for it are meningitis, which can be lethal, thankfully rare, and drug overdose from pump failure. And again, that's very rare, but a patient has to be told about that. So we're going to talk about end-of-life hospice nursing. I have tremendous respect for my hospice. Yes, James?
Sorry, before you go on, you said the MS content, you can keep increasing it, but why was that?
The MS content you would increase if the patient is using the immediate release morphine too frequently in between for breakthrough pain. So if they're popping an immediate release morphine every hour, every 2 hours, it's obviously their pain is not being appropriately controlled. So we need to up the med for that background 24/7 pain. Does that make sense?
Yeah, but you said there's no risk of something.
Oh, there's no ceiling effect with morphine, so you can give higher and higher doses
Oh, okay.
of the drug.
Thank you.
You're welcome. So the IOM Institute of Medicine has a Dying in America guideline. This is only here as a reference if you are someone who's interested in hospice or palliative care. Know that it is a specialty of nursing. It's very rewarding, very difficult work, but again, strictly there as a reference. End of life is the final weeks or months of life. For somebody to qualify for hospice, it has to be the final 6 months as determined by their healthcare provider. Our focus is on pain and symptom management. Obviously, it requires tremendous compassion. It is an honor and a privilege to be at someone's bedside in their most vulnerable final moments of life. Don't ever forget that as a nurse. You will all provide end-of-life care regardless of the setting that you work in. So always be sensitive to that fact. The family is letting you in to their life. Again, a very vulnerable time for them, the most vulnerable time for them. Families will never forget you, like ever forget you. They will stop you at ShopRite. So they will appreciate the care, the compassion, and the kindness that you extend to them and to their loved ones. You're not going to memorize these statistics, but just so you know, most people would prefer to die at home, not the way it plays out necessarily. Know that hospice care can be given in a variety of settings. It can be given in a home setting, but not every family can handle their loved one dying at home. They may find going back into the room where their loved one passed away difficult for obvious reasons. So not everyone can handle that. So there's options. There's freestanding hospice agencies. There's one in Brantford, and it's beautiful. There's oncology units in your acute care hospitals that reserve a bed or two for hospice patients, inpatient hospice. At St. Mary's, there's an agency called Vitas. It's in Middlebury. They provide home hospice for those wanting to die at home, but they also provide an inpatient. They rent a floor at St. Mary's Hospital on the 4th floor, and they provide inpatient hospice services as well. So it can occur in a variety of settings. Family members often will have dissatisfaction with care for their dying loved one. In hospitals, it usually centers around either poor communication, someone's pain was not managed appropriately in the family's view, or the family's needs were not attended to or met. The family wasn't considered. We always talk about the patient being the center of care. In this case, it is really the patient and their loved ones, right? Because the loved ones are going through the crisis as well, and we're supporting them all. So in terms of clinical manifestations, the earliest physiologic change we see when someone begins to actively die is hypotension, low blood pressure. In terms of emotionally, what we see in those final weeks of life is the person will emotionally withdraw. And we do talk with families about it. We prepare them for that fact. Most people do it. So even if the family member is talking with them, engaging in a conversation, the person is sort of distant, sort of far away, not really engaged in the conversation, not really focused on what's being said. Sometimes they physically detach. They're at a family celebration and they'll physically get up and go into another room. It's more of a subconscious thing, but it happens commonly. They withdraw, I think in some ways to spare their loved ones the pain of, sort of get them ready for that final loss. But it's common. We tell families it's nothing you did or said, so don't beat yourself up. This is a behavior we see commonly in people who are dying. Okay? The person who's dying oftentimes reaches that stage of acceptance. They accept that science and medicine has done all it can do for them. And the family takes a little longer to come around to that, understandably. In terms of symptoms like dyspnea and shortness of breath, we manage them. But remember, hospice setting is totally different from everything you know and learned about nursing to this point. And if we're on the med surg floor and somebody desats, we're all over that, right? We're going to manage that. We're going to up their O2. We're going to get them on a non-rebreather if it comes down to it. We're not even necessarily doing O2 sat levels in hospice, right? We're not being aggressive because it's not about extending life anymore. It's not hastening death, but it's not extending life either. That's not the focus for hospice. The focus really is pain management. Every cancer patient, every terminally ill patient will say to you, listen, I'm not afraid of dying, but I am afraid of suffering. And so that really is our focus. We're not going to hold morphine because of somebody's respiratory rate like we would on the med surg floor. So the rules are different in hospice, right? Take some adjusting to. The anorexia, the nausea, the dehydration, very difficult. Probably one of the biggest challenges for families is when the patient stops eating and drinking, but that happens again days before they pass. I'm going to talk about feeding tubes in a moment. Altered level of consciousness. This is when they get drowsy. Usually their kidneys are failing, the toxins are building up in their blood, and the impact it has on the brain is that the patients slowly they become increasingly confused, but then they usually go to sleep and pass away.
Say that again.
So that when the kidneys fail, remember I said hypotension is one of the earliest signs. So hypotension, we know the kidneys are not going to get perfused. When kidneys fail, there's a buildup of toxins in the bloodstream that has an adverse effect on brain function. So it affects their level of consciousness. They get increasingly confused, and then they get drowsy and sleepy, and then they eventually pass away.
Like uremia, right?
Mm-hmm.
Uremia?
Yeah, like end-stage renal failure. Yeah. There's something, oftentimes we prepare a family, many of them will have, we call it deathbed visits. Has anyone ever heard of a deathbed visit or seen it in a family member? Say it.
I'm not really sure what you mean. Yeah, I've seen a lot of that, but I'm not sure what you mean.
So a deathbed visit it's actually a visual or auditory hallucination. It's usually by a family member who's previously died. So the loved one who is actively dying will swivel their heads to an area in the room where nobody is standing, and they'll begin having conversations with family members who have passed before. It's fairly common. We call it a deathbed visit. It is in essence an auditory visual hallucination, but we prepare families for it. That does happen. It is seen oftentimes in hospice. Talk to any hospice nurse, they will tell you they've seen it.
I've seen a sudden burst of energy.
Okay, so you saw a sudden burst of energy, so I want to hear more about that. So the sudden burst of energy you saw is called terminal.
I don't know what it's called, but they were, very lethargic, and then they're just like very alert and with it and active. One particular case I can remember, lady was in a wheelchair, she kneeling herself on the hallway and everything, she died like that night.
Yeah.
And then they came the next morning early.
So that, the term for that, you described it beautifully, you described it perfectly. The term for that is terminal lucidity. Terminal lucidity. And so we call it, hospice nurses call it the surge. Some people call it the last hurrah. But it's a patient who's near death, and they've been unresponsive for days, maybe even weeks on end. And all of a sudden, they wake up. As awake as you are, hopefully, here today, awake as we are now. They wake up, they're talking, they're engaging, and it lasts usually a few hours. It can last a few days, but typically it's a few hours. And that's usually when death is pretty close. Death is imminent generally within a day or two. But again, prepare families for that, because they can think this is like a miracle, when in essence it's not. It's something that indicates death is soon.
It's kind of crazy because in both instances where like that last mirage was there, it's almost like I've seen it where like the patients are using that moment to say their goodbyes or tell them certain things that they love about them or whatever the case is. So it's like a beautiful thing for the family to experience. And then the same thing with like the spiritual visits or whatever, like hallucinations, like it also gives the family some relief, like they feel like maybe that person is coming to take them.
Right. Right. It can be reassuring for families. It can be unsettling for families too, but it can be reassuring. Yeah. So I think that's all I want to see. And in terms of clinical manifestations, the psychosocial needs, not only of the patient, but of the family as well. This is a team approach. The care we give is very holistic. Members of the team are our social worker colleagues. We have counselors. We have APRNs, PAs, and physicians who specialize in palliative and hospice care. Bless you. And as an RN, as a soon-to-be RN, you too can become a hospice nurse. Very rewarding work. Giving someone a dignified death is very meaningful and very rewarding work. Not for everyone, and it's difficult, but it can be very rewarding. We help them with their anticipatory grief, making final preparations, saying their goodbyes. I will say to you, for the loved ones left behind, we do encourage, it's the whole family dynamic thing, and families will disclose to you everything because they're so vulnerable. So you'll hear about the family dysfunction. We're not therapists, we're good, but we're not that good. It's not our wheelhouse, but we can refer them to counseling. We can get a counselor in there to help work through whatever the family drama is, right? For the loved ones left behind, if they don't resolve it with the person who's dying, it will be very difficult for them to ever process their grief in a healthy way. So we really encourage working through that. Legal and ethical considerations, just anytime a terminally ill patient is admitted to our unit, depending on what setting you're working in, the first thing we're going to find out about is what are your end-of-life wishes. That is the first thing we want to find out about. When they come to us, we want to make sure that we have the appropriate documents in our electronic healthcare record and that they're signed. You're familiar with DNR and DNI. You may not be familiar with CMO. That is comfort measures only. Again, we see that on hospice. Not to be aggressive with that patient. Focus again, not on extending life, but not hastening death either. Euthanasia and assisted suicide. Active euthanasia is not legal in any of the 50 states. That is actually administering, a healthcare provider administering a lethal dose of anything to someone. However, assisted suicide is legal in several states. It's legal in California, Oregon, Hawaii, Maine, Vermont, and believe it or not, today it's being voted on in Connecticut. It comes up almost every year in Connecticut, it gets voted down, but they're actually voting on this bill in Connecticut today. So stay tuned. Oh, I was right, it's gonna be interesting. So euthanasia, again, assisted suicide, rather, legal in several states. There was a pathologist, I don't know if anybody remembers Dr. Jack Kevorkian. Dr. Jack Kevorkian was a pathologist. He assisted in about 130 assisted suicides back in the 90s, I believe. He developed a device where the patient could administer their own lethal dose of a med. He ended up in jail because he was videotaped actually pushing the button and administering the dose. And when the healthcare provider actually puts the pills into somebody's mouth or pushes that button on that device, that is then active euthanasia. That is against the law in all 50 states. And that is why he served a stint in prison. He did die in his 80s. I think he used this machine and did it on himself. But anyways, that was Dr. Jack Kevorkian. So we'll see. Stay tuned for Connecticut. Palliative care. A lot of nurses get confused. A lot of practicing nurses are confused about the difference between palliative care and hospice care. So I want you to understand the main difference between the two. Palliative care is not strictly just for cancer. I think we always think of hospice and palliative care strictly for cancer. It's for any chronic terminal illness. Any chronic condition that's going to end in someone maybe not living out their full lifespan. So it can be Parkinson's, it can be COPD, it can be chronic kidney disease, and certainly can be cancer. So palliative care consults should be called as soon as the patient is diagnosed. It doesn't always play out that way, but ideally that should begin years before the person is ready for hospice. Palliative care is focused on extending life. It is focused on symptom management. And again, the sooner they start it, the better. And you as a nurse will have to advocate for palliative care consults on your patients in the years to come. Hospice care is a form of palliative care. Hospice care, the focus here again is different. Not on extending life, not hastening death, but providing death with dignity. Making sure that pain is controlled. That is our primary perspective. We do talk with families about bereavement counseling. It is available to them for up to a year after the person passes. It is covered by insurance and Medicare and Medicaid, and I would strongly encourage people to do it so they can process the grief. We talked about the holistic team approach. This just summarizes the main differences between palliative care and hospice care. Palliative care is years, should start with diagnosis, focuses on symptom management. The focus is on keeping them out of the hospital, keeping them home as much as possible. Relieving symptoms. Hospice care is exclusive to the last final months of life, does not focus on extending life, does not hasten death either, and focuses on helping the loved ones through the process. In terms of lifespan consideration, end of life for children, you want to consider the child's developmental age. Again, not exclusive to just cancers, it can be any chronic childhood illness. We have to be sure that the parents understand and are realistic about outcomes for the child. They have to have those courageous conversations about end-of-life wishes for children who have chronic illness. Lifespan considerations. So what are some of the barriers to palliative care in children? Some of it is they may just live in a geographic area where it's not available. They don't have a palliative care practitioner available to them, someone that's trained specially in palliative care. Sometimes they have a parent who's not ready for it. Palliative care doesn't mean the end, and a lot of people get confused about that, nurses too. Palliative care is not the end. Palliative care is symptom management, keeping them out of the hospital, helping them control all of the symptoms associated with their illness, pain among them. We have to keep lines of communication open with the child and the child's parents, making sure that everyone is on the same page. There may also be obviously financial and cultural barriers. There's some legal ethical considerations for adolescents who have terminal illness. There is, I don't know if anyone remembers this case. It was a while ago. It was probably around 2015, but it did happen here in Connecticut. Anybody here is from the Hartford area. This young woman, Cassandra, was diagnosed with what was felt to be a curable cancer, and she did not want treatment. And her mother supported her in that. She did not want any sort of treatment for her cancer. The healthcare team felt confident that she had a highly curable cancer, and they felt the mother and daughter were missing appointments. This young woman ran away at one point. This went to the Supreme Court level, where the Supreme Court determined that she was not mature enough to decide in her own best interest. And so this is very extreme, but the court ordered that she be removed from her home, which she was. She was mandated to Children's Medical located on the Hartford Hospital campus, and she remained there for several months receiving cancer treatment. She, in the end, did pass away, unfortunately, at 22 of cancer, but this was a big ethical debate, as you would imagine. And so she did not feel that her voice was heard. I will tell you that later in the process, when she was 20, she did choose to have therapies, but that initial choice was not really hers. She was court mandated to have it, which was, again, a legal ethical dilemma. And there's a link there to it if you want to know or read more about her story. But it's called the mature minor doctrine. And the state of Connecticut judicial court and Supreme Court did not feel she was mature enough to make her own decisions. So that's what I mean by ethical issues here.
If somebody's mentally impaired, how does that work? Are they still able to use their voice to make those decisions or not?
They would have to have a healthcare proxy assigned to them, to make those decisions, or somebody appointed by the court. Parents making decisions about withdrawing or withholding treatments. Again, in the final weeks or months of life, many parents will choose this. They can no longer bear to see their child suffer. They don't want to prolong their child's suffering, and their decision is honored. DNR orders need to be signed and on the electronic health record as with adults. We consider always spiritual and religious beliefs we support, and the only way for you to know it is to ask the question. Do you have a particular religious practice or belief or a spiritual practice that would be soothing to your loved one or to the family that we can make happen for you? The only way to know it is to ask, right? Because every culture has its own way of death practices. Collaboration, we talked about the team approach of holistic care. Pain, again, our concern with morphine dosing is we're going to err on the side of keeping the patient comfortable. This is a different setting than the med-surg floor. We're going to relieve any other symptoms they have. If they're short of breath, you can give them oxygen for comfort. You can put a fan in the room. Again, we focus on pain management. We want to give them death with dignity in the end. Feeding tubes, what I want to say just briefly in our final few moments here, is feeding tubes. Some families will, and certain cultures, I feel like you can always pick on your own culture, and I'll pick on my own culture. I'm half Irish and half Italian, but the Italian side of the family, like many other cultures, in our culture, food is love, right? So if someone's sick or dying, we think that's the answer to everything, food, food, food. So it's very hard for cultures. And what their family will say to you as the nurse standing there is, so you're going to let my loved one starve to death? We're all going to just stand around and watch my loved one starve to death? And a way that you can respond to that, how you can frame it, is the truth. I'm not going to lie to them ever. So the truth is, when somebody is actively dying, all of their body systems are shutting down, right? One by one. The gastrointestinal system is shutting down. They no longer have the capacity to process nutrients. So if they can't process those nutrients that we would be forcing in with the tube feed, they're gonna have bloating, they're gonna have cramping, they're gonna have aspiration of the tube feed, making their breathing more difficult. In the end, force feeding an actively dying individual increases their discomfort the whole way around. So if you can educate them very kindly, as you would, and diplomatically, in that way, they then can buy into and honor that, then they have peace with, I didn't just stand there and let my loved one starve to death. Does that make sense? Same with IV therapy and hydration. The ANH withdrawal here is artificial nutrition and hydration. We're not gonna hang up IV fluids and hydrate them. It's too late for all of that, right? CPR, I mean, if there's for some reason not an order on the chart, we'd be legally bound to do CPR and err on the side of life. But again, somebody who's terminally ill, those discussions have been had, and there should be the appropriate paperwork in the patient's chart. The nursing process, again, that's pretty straightforward. I'm not going to read that to you. The nursing problems, again, straightforward. I'm not going to read that to you because Professor Kelly has to start her content. Nursing interventions, if we talked about all of these. I just wanted to mention briefly in the final moments here, postmortem care. When we do postmortem care on the person after they've passed away, it involves bathing the body. There are some cultures that prefer their family to bathe the body. Some cultures don't want, in some cases, a female bathing the body. So we honor that. If the family wants to come in and bathe the body, that's fine. Typically, my practice has always been to do postmortem care is to bathe the body. When they're here, I put their hands outside the blanket in front of them so people can kiss their hands or hold their hands or touch their hands, the family, when they do come in. You want to adjust the lighting in the room. You want to make it appear as though the patient is sleeping as best as possible. If their mouth is hanging open, I'll roll a little washcloth underneath to try to bring the jaw up a little. If the eyes are open, obviously we'll close them. So again, just making them look presentable, tidying up the bedside. It's traumatic enough for somebody to come in that moment. You want to make the person look as peaceful as you can. Always, I don't need to say this to you, but always provide dignity to anyone, to a body, to someone who has died. Console the family, offer them hydration. When the family leaves, they will take personal effects with them. There's paperwork at the hospital where you document the jewelry, specifically what went home with the family. The patient will then have identification tags placed. They'll be placed in the shroud. They'll go to the morgue and the funeral home. We'll pick them up in the hospital morgue and take it from there. So that's it. I'm sorry, rapid fire. Professor Kelly, come on down.
Okay. They didn't have a break.
They did have a break, but they can do a stretch break if you want to come down.
You want to take a 10-minute break because I have to log in and everything. But before you go, make sure you guys are all checking your phones in the morning. You know there's a forecasted weather event, whatever.
Just canceled
So
today.
make sure you check, to see what on my comment alert. They'll tell you.
No, so just cancel it.
And whatever you don't have to wake up. That's up with you as far as it comes out in January. They do the estimated cancer cases and the deaths from cancer in the United States. So I like to look at it, but pretty much it hasn't changed much in the past 10 years. But it kind of is a good way to look, male and female, to compare, and what are the most common cancers, okay? So they have this nice graph, or whatever you want to call it, and they have one which has the top deaths. So you can see for males it's prostate, then number 2 is lung, then colon, bladder. And if you see, number 5 is melanoma for both males and females. So we're going to talk about melanoma, but first we're going to do leukemia. Leukemia is further down on the list, right, for both male and female. It's not the most common cancer, but it is significant if it made the list. But it is the most common cancer in children. So you're going to see in our case study, in a lot of the presentation, we're talking about children, because leukemia is the most common type of cancer we see in children. So what is leukemia? It is a blood cancer, a hematologic type of cancer, right? Little different than the cancers you've been discussing, tissue type cancers, where there's a tumor, right? With leukemia, there's no tumor. It's in the blood cells. It's in leukocytes that start as stem cells in the bone marrow, where the abnormal gene, right, a mutated gene, you guys know the one base physiological first step process in any cancer is the mutated gene, right? Whatever caused the mutation, it could be radiation, it could be chemicals, it could be all these other things that can cause a gene mutation that then proliferates and grows. So leukemia is an uncontrolled proliferation of malignant leukocytes in the bone marrow. Okay? So we got to think about a little different, right? A little different type than what you've been talking about. Yes, the leukemia can then spread to other organs, the central nervous system, the lymph nodes, the spleen, but it starts in the bone marrow. It's a hematologic cancer. And you guys have, it's on the next slide. On this slide, I know this is pathophysiology, and normally we don't have time to do patho, but again, since it's probably been a while since you've had your A&P, I wanted to put up this picture of the development of blood cells, originating all from that one stem cell that starts in your bone marrow, okay? The step one, it comes from all this one hematopoietic stem cell, then differentiates and grows into different blood cells. There's two main branches, the myeloid and the lymphoid. So when we talk about leukemia, the different types, it depends which stem cell it originates, myeloid or lymphoid. That gives us our different types of leukemia. And then you can see as the cells grow and differentiate and proliferate, they develop into different type of blood cells that you all know about. Red blood cells, platelets, granulocytes. The white blood cells are granulocytes, right? And we know there's different types, basophils, eosinophils, and neutrophils. Do you remember which are the ones that fight infection and fight foreign objects in our body?
The B?
The neutrophils. Okay, so the neutrophils are going to be integral and important to the discussion on leukemia. In the lymphoid cell, further differentiates and develops into lymphocytes. Okay? Those are all white blood cells. They all have a little bit different job to help our immune system, to protect our body. That web link up there is this cute little pre-quiz, so if you haven't already done it, it's good for you. You can click on it and take a pre-quiz, post-quiz, just to see your general knowledge about leukemia. So again, a little pathophys, because it helps understand the disease, and it helps then have us understand where the symptoms are coming from and the treatment. Is a hematologic blood cancer that originates from the hematopoietic stem cells in the bone marrow. So you know there's different layers of bones. There's the hard bone, the spongy bone. The bone marrow is in the middle of the bones, right? It's kind of a gelatinous, it's liquidy, gelatinous material, okay? So that's where this abnormal growth begins. There are four main types of leukemia. It's broken down into acute and chronic. So you guys know what the term acute and chronic mean, right? So acute means it's an abrupt onset. Usually the patients are quite ill appearing when they present. And it progresses and it's more severe. So we know what acute illness is, as opposed to chronic is usually slow and insidious onset, gradual onset, slow growing, slowly progresses. And we'll see when we talk about the chronic leukemias that we see in older people, right, or adults, because children are too little to have the chronic, okay? We're going to see the acute leukemia, which is the most common type of cancer in children. The average peak age is 2 to 4. Well, they don't have time to develop a chronic leukemia. So chronic leukemia we see in 70-year-olds and adults. So it's broken down in acute and chronic, and then further to what stem cell it comes from, the myeloid or the lymphoid. So we have AML, acute myelocytic leukemia, or ALL, acute lymphocytic leukemia. And then we have chronic myelocytic and chronic lymphocytic. So as we said, it is the most common childhood cancer. And actually it's ALL that's more common, and it has a better prognosis than AML. And that's good. The diagnosis for this leukemia, now think about your A and P we just looked at, is a bone marrow biopsy. Okay? So for that definitive diagnosis to say what it is, they need to obtain a sample of the bone marrow, send it to pathology, look at it, to look at the cells and identify what abnormal cells there are. Within the types of leukemia, there's many subtypes. You do not need to memorize subtypes. I didn't even write them. But basically, they're genetically and molecularly different. The hematology oncologists do want to know that because they have different prognosis. They treat them with different chemos. So once they obtain the bone marrow and send it to the lab, they're going to get all the genetic and molecular analysis to pick the best course of treatment. But the definitive diagnostic test, and we have a picture, is the bone marrow. Usually, initially, how it's discovered is, what do you think? A CBC, a white blood cell count. Because again, it's abnormalities of the leukocytes, right? So people present with signs and symptoms, but the signs and symptoms could be other diseases, could be a cold, could be infection, could be bruising. Then they look at some complete blood cell count and see some big abnormalities, that which raises a suspicion this may be leukemia, but you need the bone marrow for definitive. There's no one identified cause, like smoking we could say directly linked to lung cancer, right? We can say certain things are directly linked. There's no direct links with leukemia, however, it's been identified. There are certain risk factors are increase the risk. And a lot of it is chemicals, benzene that's in gasoline, industrial solvents, paints, oils, coal emissions, prior exposure to chemotherapy. So as an adult later in life, you can develop leukemia as a secondary cancer from previous chemo. And ionizing radiation. So a radioactive accident, a radioactive bomb can cause leukemia. And certain congenital genetic disorders are at a higher risk. So Down syndrome is one of them. I think that's a common one you've all heard of. Children born with Down syndrome are at increased risk of developing leukemia. So, but there's no one thing that we can say, you know, like cigarette, like don't smoke to avoid getting lung cancer. We can't say that about leukemia, but we do know gasoline, benzenes, paint, and oils. So using occupational protections. So we talked about the bone marrow biopsy. So they have to actually go into the middle of the bone where the marrow is with a thick coring needle to obtain that sample. So it's a special needle. We have a picture on the next slide that kind of cores because they have to go through the skin, the subcutaneous, and the muscle, and the hard bone before they get in the middle. So it is not so much pain as pressure, but it is uncomfortable. They use local anesthetic. And for children, because we said this is a childhood disease, they frequently use a little conscious sedation because it's just the whole anxiety of how are you going to have this child lay still. The most common site is the posterior iliac crest in the back. So the patient's usually laying face down in the prone position or on their side. Nursing assists the physician with this procedure. It can be done at the bedside. It is a sterile procedure and the doctors will do it. Vital signs will be taken. And the nurse's role really is after the procedure, again, think about what we're gonna talk about. What is the clinical manifestations of leukemia is neutropenia, low platelets, so they're at risk for bleeding, right? And a bone marrow is sticking a needle into the bone, so we want to keep pressure on the site so they don't get hematoma and bleed, and observe the site for infection. So again, they can take it from the sternum, but the most common and preferred site is the posterior iliac crest. So monitoring the patient for hematoma and infection and having them lay on the site for 30 to 60 minutes to apply pressure. So I like this picture because it kind of shows that different needle, because it has to core, so they kind of twist it and core through. Again, think of what they have to go through before they can access the bone marrow. Some hard bone, right? And then it's kind of gelatinous, so it's thicker. It's not just like drawing a blood sample. It's thicker that they send to the lab. It is sterile, so it's a sterile field. They're going to clean the skin with antiseptic, use all sterile equipment. And the patient's either prone like this or laying on their side. And they do apply pressure, so. Imagery? No. Now, imagery is used in leukemia, but it's to look for metastatic disease, like if it has spread to the liver or the brain or the spleen. But for diagnosis for leukemia, it's bone marrow biopsy. So what's narrow?
The crest of it, so.
I was thinking
But I think they know.
No, they don't. No. No, they do it. I think that's why they pick that bone. It's easily like accessible. And I don't know. Yeah. No, I've seen a lot. I've seen quite a few of them done, and they don't use imaging to do it. The doctors, they know where they go right there. They keep pushing and kind of going like this. They do put pressure. So this one I liked because it showed a child, and again, number one childhood disease. And you see it's a special coring needle. I added these pictures because I found good pictures, and I try to minimize what you guys have to print out. So you don't have the pictures, but you can look at them here. This is a picture of a lumbar puncture. Why I put that on there is because one of the most common areas for the leukemia cancer cells, or the cancer abnormal leukocytes to infiltrate next is the central nervous system. Okay? Especially, mostly in that acute leukemia in children. So usually, not usually, sometimes they do a lumbar puncture to see if the leukemia cells have already spread to the central nervous system to get some cerebrospinal fluid. And it's such a high propensity to do that, they even treat them with prophylactic intrathecal chemotherapy children. And I know you may not have talked about lumbar puncture, but today's our last day for cancer, which probably some of you are happy about. And then we're going to be starting the neuro unit soon. And you are going to talk about lumbar punctures, right, for meningitis and different neurological diseases. But they will do an LP, it's called an LP, or you may have heard it called a spinal tap, for to look for, to see if any leukemic cells have infiltrated the central nervous system. So again, that's, this is a tiny skinny needle, not a bone marrow needle, going between the two vertebrae. It's a sterile procedure performed by the physician, patients laying on their side, nurses assist with this, okay? And they're taking some cerebrospinal fluid out of the spinal column. Clinical manifestations, well, let's think about our patho. What the patho is abnormal, mutated leukocytes grow and divide and proliferate. And they crowd out the bone marrow. They take up a lot of room in the bone marrow, so they crowd out the normal cells. The red blood cells, right? The platelets, and all the, the other white blood cells. So our symptoms come from being anemic, having a low H&H, and low platelets, thrombocytopenia. So pallor, fatigue, shortness of breath, and headache. Those are all symptoms of what? Anemia. Thrombocytopenia, that term means low platelets. We're going to see bruising, bleeding gums, bloody noses, blood in the urine, easily bruised, cut themselves and prolonged bleeding, petechiae rashes, that pinpoint red rash on the trunk and the back. So those are all signs of low platelet count. The leukemic cells can infiltrate to the spleen and liver, so if it's a little more advanced, they may have enlarged spleen or liver. But they're always going to have cytopenias. What do I mean by cytopenias and pancytopenia? Those are terms you guys should know. Penia means small, cyto means cells. So low counts on all the cells, right? Pan means all. So pancytopenia is low red blood cells, low white blood cells, and low platelets, right? The cytopenias we call them. That's what's pretty classic with leukemia. Now, the low white blood cells is like your neutrophils are low, but the leukocytes, because they're abnormal, they're mutated, right? Gene mutation is the base of all cancer. So these abnormal leukocytes grow out of control. It's cancer, right? And so you can have, usually the presentation is leukocytosis. Really high white blood cell count, but they're abnormal. They're not normal white blood cells. They're cancer white blood cells. So you may have a white blood cell of 30,000, 40,000, 50,000. Now I know we tell you guys you don't need to know the normal WBC, but does anyone remember the normal range? Depending, I like that I heard different numbers, because it's going to let me make a real important point that you guys already know. Depending on what resource you look at, it might say 5 to 10, 4.5 to 11, right? So you already learned that because you've been in the program now, that depending, if you use different lab books, resources, the numbers vary a little bit, right? 4.5 to 10, 5 to 11. So we're talking way past that normal range. So it's an extremely high amount usually, but they're abnormal leukocytes. It's called leukocytosis, abnormal growth of abnormal white blood cells. That's leukemia. But the good white blood cells that we need to fight infection and protect us for our immune system are not there because the abnormal ones have taken over. So we'll just briefly, we said there's 4 different types. Acute myeloid leukemia, abbreviated AML. And again, it's that uncontrolled growth of immature blast cells. There's many different subtypes. That's how the doctors determine what specific chemo regime and what the prognosis is. It usually has an abrupt onset and the patient appears quite sick by the time it's discovered because there's no lumps and bumps to say, ooh, maybe I have something abnormal, right? It's blood cells, you can't see it. The treatment for all the acute leukemias really is aggressive multi-agent chemotherapy, okay? Because again, think of what we're dealing with, blood cells. There's no tumor to radiate or do surgery on. It's multi-agent chemotherapy, and if that doesn't cure the patient or put them in remission and keep them, a stem cell transplant, another term for stem cell, because traditionally the first one was bone marrow transplant. Those mean the same, kind of the same thing. Why they call it bone marrow transplant, because the first one's done back in the 60s, I think late 60s, they didn't even, stem cell research wasn't even out there, right? You never even heard of the stem cell transplant. They would actually remove the bone marrow of a donor in surgery and put it in the recipient, the leukemia. So that's why they're called bone marrow transplant, but really the more common now, it's not using the bone marrow, they're using stem cells from the donor, and we'll talk about that. So AML and ALL, acute lymphocytic, that's our most common type in children. And again, the peak age is, 1 to 4, so they can be quite young, but any childhood age. The good news is, if it's caught fairly early or in the younger child, the cure rate is really good. It's improved greatly over the past century, and that's largely due to our new chemotherapy agents and stem cell transplants. So it has a good cure rate. It is common, however, for those acute lymphocytic leukemia cells to spread to or migrate to the central nervous system. So they may have some central nervous system symptoms, which would be headaches, seizure, vomiting, nauseous, off balance, their balance isn't good. The treatment, again, for acute lymphocytic leukemia, it's the same as treatment for AML, is multi-agent chemotherapy. Because of the high risk for central nervous system, they will put chemo into the cerebrospinal fluid, and that's called intrathecal chemotherapy.
You said they put it right into the
Yep. So intrathecal, has anyone heard that term? Intrathecal chemotherapy, is that a term? It's a term you need to know. It means putting the chemotherapy into the central nervous system. Why do we have to do that? Is because most chemo you learn is given intravenously, right? And if it's not targeted or immune therapy, it has a systemic effect. Given in an IV, preferably a central venous access, right? Because we know they're quite caustic to the veins. However, because of the blood-brain barrier, if you give peripheral chemotherapy from a central line, it's not going to cross into the cerebrospinal fluid because of the blood-brain barrier. So they actually infuse it, administer it into the central nervous system through a lumbar puncture or something called an Ommaya reservoir that they put in their brain.
Yeah, my mother-in-law has a port in her head right now for that.
Oh, for intrathecal chemo?
Yep.
Okay.
She has lymphoma.
Lymphoma,
And
okay.
it's spread to the
So
center.
lymphoma, and thank you for bringing it up. So lymphoma is another type of hematologic cancer, right? Leukemia is not the only one. I did voice over the lymphoma PowerPoint. So it is there. I've had it up for a couple of weeks. If you have specific questions, we don't have time to cover it all. There's a lot of similarities between leukemia and lymphoma. At the end of this, I'll highlight some differences. But the treatment, again, chemotherapy, and because of the blood-brain barrier, if you give chemo in a PICC line or a port, it's not going to get into the central nervous system. You have to put it in the central nervous system.
And she has both. A port for the body, a port for the brain.
Right, so you need, if you have leukemia, you're going to have a central line. Because you're talking long-term chemotherapy. In children, it's about 2 years. It could even extend. It's long-term chemotherapy to treat this. So it's not as simple as some of the solid tumor cancers, like, oh, there's a tumor, let's cut it out, cut out the margins, take out the lymph nodes, and hopefully cure it. It's a long-term chemotherapy treatment, up to years. Yes?
I'm not understanding where to put in catheter.
I have a picture.
Okay.
It's hard. It's called an Ommaya reservoir. So they put the catheter in the brain and they make like a little, like a port reservoir, right? Or that lumbar picture I showed you, they can insert it that way. But to get into the central nervous system, to put the chemo in the cerebrospinal fluid, you have to get in there. You can't do it systemically. The chemo won't get into the brain and the spinal column. So the chronic leukemias, we said, obviously those are older adults. They come on slowly. They come on insidiously. Some people don't even know they have it for years. They can have it for years. They're not symptomatic. Sometimes, often it's caught by accident. Like incidentally, they go for a routine physical, and the doctor does blood work and notice that their white blood cells are, not normal. So the chronic disease is very different. It can be, oftentimes they do the watch and wait. I think you heard that maybe with another cancer, maybe prostate, watch and wait, or someone said, no, it's watch and worry, because they don't necessarily need treatment right away if it's in the early phases. There's some people, I know someone that's had it for 5 years, and he hasn't had chemo yet. He's like in the late 80s. I think he's in his late 80s. They just monitor his labs. So if it's not progressing and the white blood cells aren't to this certain point where there's so many abnormal, they just sort of watch and wait, right? At some point, if it does convert and get more aggressive and the abnormal cells grow, they will give them some oral chemo. But the symptoms, again, they may be asymptomatic for years, and then just sort of like they're fatigued, they're tired, weight loss, they may have shortness of breath, night sweats and fever. So it all depends what phase they're in and what type, and what comorbidities they have. If they're in their 70s or 80s or 90s, they're not going to be giving them aggressive chemo, right? Because people who are very elderly maybe have underlying kidney, liver, heart disease, and lung disease. What do you think about them tolerating aggressive chemo? It's hard. It's going to be hard, right? Because a lot of these chemos, as we know, have side effects that are toxic to the lungs and the heart, right? And the filter to the kidneys. So they take a lot of things into consideration, but one of the main treatments for chronics is oral targeted therapy and immunotherapy. And these tyrosine kinase inhibitors, TKIs, so back to general treatment of acute leukemia, it's combination or multi-agent chemo. Why do you think? Oh, I have the reason why up there. Have you heard this again? You've been hearing about cancer now for a couple of weeks. Did someone else talk about why would they use more than one specific drug?
Because of the cycle of the cancer cell?
Perfect, because you guys remember that cell cycle, right, in your A&P. So different chemos will attack or stop the cell division at different points in the cell cycle. So they use different chemos that work differently in the cell cycle. Also, using different types of chemo decreases the chance of developing drug resistance. Have you heard of that? So some people that have certain chemos, they may get this certain drug for 6 months, right? And then after that, it doesn't work anymore to kill their cancer cells. They have to switch to a different chemo. So it's almost like the antibiotics, develop drug resistance, right? The bacteria to antibiotics. So cancer cells can do the same. So using different types of chemo help decrease development of drug resistance, attack the cell at different points in the cell cycle, and we can usually give them at lower doses to minimize the toxic effects. So they always use more than one chemo. And frequently, if they don't put them in remission and they're not successful, sometimes they go into clinical trials. And clinical trials are important. Why? Helps research to develop new chemotherapy drugs, right? So one thing we can say, in the past 20 years, the survival rates of cancer has really greatly improved, right? Leukemia used to be a death sentence. Not all that. When I was a kid, 60s, leukemia was a death sentence. It's really because of the new chemos. Well, the only way we can develop these new chemos and know they're effective is through clinical trials. So clinical trials are important. So we talked about intrathecal chemo. That's chemo administered into the cerebrospinal fluid. If the disease has spread and went to lymph nodes or anything, they may use radiation. And if chemotherapy doesn't put the patient with leukemia in remission and keep them in there, a stem cell transplant is a treatment option. So they don't do stem cell treatment first. The first choice is chemo.
For the stem cell treatment, they start doing like plastic and all that?
Oh, yes, yep, I have slides on the stem cell. I was trying to, so I know this is like your 5th lecture in cancer. So some of this is a lot of repeat, right? Side effects chemo, side effects radiation, the pancytopenia, all that, weight loss. That's like repeat. That's repeat concepts now you've been hearing since you had the cancer. So I try to pick out what's different and unique about leukemia. The diagnostic test, bone marrow. The treatment is chemo. You guys already heard about chemo. You don't have to memorize any names of specific chemos. You know that, right? But the stem cell transplant you may not have discussed yet. So we're going to spend some time on that.
I'm sorry, because I wasn't here on Monday, so it was mentioned, I'm sorry, guys.
No, I don't know, because my dad, I didn't ask the other faculty if anyone talked about stem cell transplants. I don't know. No. Okay. All right, so chemo for acute leukemia is done in 3 phases. And I told you it's long term, up to 2+ years for children. And usually the initial phase is called induction phase. So that's when the patient's first diagnosed. Their leukocytes are way out of the ballpark high, but they're not normal. They're called immature blasts, they're abnormal. So they usually hit them with aggressive high-dose chemo. They're usually quite ill from the side effects, and it usually requires hospitalization, and it can be anywhere between 4 to 6 weeks. They're going to need a central line, lots of IV fluids. They're at risk, big risk with hematologic cancers for a complication called tumor lysis syndrome, which I think you've heard about. You talked about it as causing AKI, acute kidney injury, and we're going to talk about tumor lysis syndrome because, again, that's pretty much a complication linked to lymphomas, leukemias, multiple myelomas, those blood cancers. So induction chemo, and then that's 4 to 6 weeks, and then they do consolidation, which the goal is to kill any remaining leukemia cells that they didn't kill during induction. They can use the same drugs at lower doses, or maybe they'll use different drugs. It's really to kill any residual leukemic cells. And then they'll go on maintenance chemo, which again is months to years, where they'll be getting some chemo every couple weeks. That is to keep the leukemia away and hopefully keep them in remission. So here is the picture of how they would administer or infuse chemotherapy into the central nervous system. Through that reservoir that's placed in the brain, and then the catheter goes down into the ventricles of the brain. That's where they could infuse or insert or administer whatever term you want, into the central nervous system. Or the lumbar puncture, which would be the needle between the vertebrae, and usually it's the lower thoracic or upper lumbar spine. Okay? Because if you give the chemotherapy in a peripheral site, it's not going to get into the cerebrospinal fluid. I like the pictures too, because if I talk about the Omiya Reservoir, do they call it Omiya Reservoir for your mother-in-law, or just some reservoir?
That's not, the doctors probably called it that, but that's
Yeah.
not what they call it. It's kind of like
A port.
exactly.
It's a port. It's a port. So, All right, I want to spend a little time on tumor, or a couple combinations that we see. I didn't know why that's on there. Tumor lysis syndrome, TLS, you've heard about. Basically, it's the result of this massive cell lysis, which means death, right? So the leukocytes are sky high, 30, 40, 50,000, right? But they're abnormal, mutated, and they're in the immature phase. So they hit them with hard induction chemo, kill a bunch of these cells, so all the inner cell debris goes out in the bloodstream, and it gets filtered through where? Kidneys. So that's really what you need to know about tumor lysis syndrome. It's very common with blood cancers, right? So it's very common with blood cancers, especially when they give that first round of chemo when you have such a high count of cancer cells. So how do we monitor? We need to monitor the BUN and creatinine, right? It can cause acute kidney injury. And it causes a high uric acid level, hyperuricemia, high phosphate level, high potassium level, and low calcium. So similar to what you just learned when you learned kidney disease, elevated potassium and phosphate. The treatment really is tons of IV fluids, and they do this preventively when they start chemo. They'll load the patient up with 2 liters of fluid before they even give them the chemotherapy. So lots of IV fluids to keep the kidneys flushed out. Monitor renal functions. Close intake and output. And the drug that I think you've all heard of, allopurinol, what do we use that drug for? To decrease uric acid. Gout is the one you probably know it. So it's a drug you know, allopurinol or xyloprim, decrease uric acid. Huh? Oh, for kidney stone you learned about it?
Yeah, but the uric acid.
It can cause a kidney stone.
No, but the uric acid.
Yes.
The uric acid is
Yes. Oh, and so now you learned another use for that. Besides gout, in tumor lysis syndrome, if the patient's uric acid is high, they'll give it. They may prevent it all by giving a lot of IV fluids. So obviously monitoring all those electrolytes and renal functions, right? And phosphate binders if needed. I have no reason, I don't know why that's running in the background. When you guys looked at this, my voice was in the background. Okay.
It's just on that slide.
God only knows it's the cyber, whatever. So again, I like pictures, I'm a visual learner, so I thought this was a good picture of tumor lysis. You came up to help me. I did. What do we need help with? Is the voice still on?
It's just on that one slide.
I didn't think there was another slide still. All right, what's your name? James, I'll call you up because I might need your IT. Boy, James is at 12, huh? All right, so I like pictures. I'm a visual learner. This kind of shows you the bloodstream with the red blood cells going through, right? It shows you the cancer cells being smashed apart and killed and all the debris is coming out. And then all that debris from the cell lysis gets filtered through the kidneys, resulting in high potassium, phosphorus, and uric acid. And we know what happens with high potassium. We can have cardiac dysrhythmias, right? We can have muscle cramps and weakness from low calcium and seizures. So this is, high risk tumor lysis syndrome. All right, so back to another form of treatment, targeted therapy, which we do with the chronic leukemias. So targeted therapy is different than general chemotherapy by what? It's all in the name. It's targeted. Right, I love it when the name says what it is. So it targets specific protein on the cell. It's more targeted. So less likely to cause damage everywhere in the body, right? Because that's the double-edged sword with chemo. General chemo, traditionally we're giving it to kill the cancer cells, but we didn't have a way to say, just go to cancer cells and kill them. Don't kill all the other cells in the body, right? The skin, the hair, the mucosal lining. So with targeted therapy, that's all you need to know. It's targeting specific cell receptors. So the one we see used commonly with the chronic leukemia is this TKIs, or tyrosine kinase inhibitors. Yes, they do have side effects, even though they're oral, and the side effects aren't as drastic as IV chemo. They can cause edema, fluid retention, myelosuppression, another word you should know, especially related to blood cancers. What's myelosuppression mean?
Pancytopenia?
It causes, myelosuppression causes pancytopenia, right? So if that's not something concept get, myelosuppression means what? Suppression of what's myelin? The bone marrow. So chemotherapy and radiation can suppress the bone marrow. Not just chemo, radiation can too, right? And if we suppress the bone marrow, we know that bone marrow produces red blood cells, white blood cells, and platelets, so it causes pancytopenia. So if the chemotherapy doesn't put the person with leukemia in remission and keep them there, so cure them, another treatment option is a stem cell transplant, which we use interchangeably with the term BMT, bone marrow transplant. And the only reason is traditionally back in the 60s when they did the first one, like I don't even think they knew about stem cells. They actually went in and surgically removed the bone marrow from the donor and put it into the cancer patient. And the name kind of just stuck. You may also hear it called a hematopoietic stem cell. But for our purposes, we're keeping it short and sweet, stem cell transplant. Stem cells can be obtained from a donor, a family member, umbilical cord blood, or from the bone marrow. Used to treat blood cancers, not just leukemia, but multiple myeloma and lymphoma. There's two main types. Allogenic is from a donor, allo, somebody else. It could be a family member or an unrelated donor, but we have to have tissue matching, and that's what you were referring to. So you know when you give a blood transfusion or FFP or platelets, right? It has to match, so you don't have a blood reaction. So that's what has to happen with stem cell. They have to match the HLA human leukocyte antigens. So they do a lot of matching. Otherwise, there's going to be a rejection. So it's a blood product, so it has to be typed and cross-matched, even more than blood though. They do HLA matching, and it's at least 7 or 8 different antigens. The other type of stem cell is autologous, auto, their own. So some types of cancer, the patient's stem cells are removed before they start treatment and frozen. They freeze them. And then they can later on infuse them back into the patient. That's called an autologous stem cell transplant. A stem cell transplant is a very rigorous treatment. Not everyone could withstand it because it's very, not so much long term, but we'll talk about what it is and you'll see that. They have to screen people. Now the children, no problem. Young adults, no problem. But if you have an elderly person, they have to screen them to make sure their lungs are healthy, their heart is healthy, because the treatment and the pre-treatment or conditioning is very rigorous. So if they're not going to survive the pre-treatment because they have severe lung disease or kidney disease or heart disease or liver disease, then there's no point in doing it. So if you're going to kill them with the treatment, there's no point. It's always risk to benefit, right?
I have a quick question. If they give themselves their own stem cells back,
Yeah.
are they at increased risk for recurrence of cancer or no?
Depending on what type. So it's done more for multiple myeloma, but yes. So if you haven't already listened to the lymphoma, which I think that's what my voice is coming through. In the lymphoma PowerPoint, I threaded a real life case. I knew this girl, when I started lecturing about this, I went to like fundraisers. She did, in there, it's threaded through her case. She had an autologous once or twice, and then she had an allogenic stem cell. So if you have a very resilient cancer that keeps coming back, you may have more than one. But with the leukemia, especially the childhood, the cure rate is good. Most of them are cured with just the chemo, but they do well with children with the stem cell transplant. So there is a screening, physical, to make sure they can physically withstand it. Also psychosocially, it's rigorous, financially, the whole bit. Then, before they get the stem cells, basically they have to wipe out their bone marrow, right? Because that's where the disease is, the cancer. So basically they try to kill almost all their cells in their bone marrow. They do this with chemo and total body radiation. And they do that 5 to 10 days before the stem cell. So basically what a stem cell is, you take the patient with leukemia, destroy their bone marrow, destroy all their cells that are potentially leukemic and cancerous, and then you rescue them with the stem cells of some donor that's healthy. And hopefully those stem cells migrate or go into the bone marrow and set up shop and start to grow. That's called engraftment. Another word you should know. Familiar with engraftment? It's a word kind of specific to leukemic and stem cells. So once they infuse the donor stem cells, that's called day 0, then those stem cells that they put in through a central line, right, have to migrate into the bone marrow and start growing new. And hopefully a new healthy bone marrow and healthy cells. That's called engraftment. During that time, the patient is extremely vulnerable. It's critical, right, critical care. Because they just have their whole blood system wiped out pretty much. So they don't have any platelets or neutrophils. So what do you think they're at high risk of dying for?
Infection.
Infection is leading to death. So in the pre-treatment or conditioning, they eradicate all the malignant cells in the bone marrow. So that's all the cells. Then they infuse new healthy stem cells and hope and pray that they grow and take over, right? But that takes time. It's 10 days, 14, 10, 21 days. Because you have to know the cell cycle, right? So the stem cells have to get into the bone marrow and sort of plant the seeds, and hopefully they'll start growing new red blood cells, new platelets, and new white blood cells. And they monitor them every day. They're going to have a CBC to monitor those levels. During that time, the patient is critical. They're in strict isolation because they have no ability to fight immunity, and their platelets are extremely low, so they're at high risk for bleeding. So they're on strict isolation. During that time, they're getting multiple IV medications, platelet transfusions. Usually they have such bad mouth sores. And what did you learn about general chemo? What cells do chemo affect? The GI system, right? The mouth, excuse my French, but mouth to anus is going to be wrecked. All your mucosal lining. So they have diarrhea, they have mouth sores. They really can't eat. They're usually on IV nutrition, okay? For a certain amount of time post-stem cell, because they just can't get enough nutrition. So very usually like one-on-one nursing for those first week. Back to harvesting stem cells, that's when they take them from a donor. We said it could be from a matched donor, which has that HLA matching, or their own stem cells taken out. Or they can also get it from umbilical cord blood. Now, when you have a baby, I guess there's a way you can store umbilical cord blood. Keep it frozen for future, in case it's needed for future use. One way that donors can donate, or the way that donors, not one way, the way that donors donate stem cells, it's like giving a donation. You're sitting there in a recliner, hooked up to the machine that takes your blood out, filters out your stem cells, and returns your blood. It's an apheresis machine. Before they do that, they want to increase growth of neutrophils, right? Because the neutrophils are really, that's what we need to fight infection. So mobilization of neutrophils is giving one of the hematopoietic growth factors. So I'll answer that in a minute. So what am I talking about? What are the growth factors?
Neupogen or?
Neupogen, right. Neupogen, it's all in the name. Neupogen is the growth factor for neutrophils, right? Mm-hmm. And what's epogen the growth factor for?
Red
blood cells. So they will give that person some Neupogen, or that's, I think, the brand name, but it's a granulocyte hematopoietic growth factor. What? Filgrastim, thank you. I was like thinking Neupogen because I think neutrophils Neupogen. So that helps the donor produce a lot more neutrophils. So then when they go to donate, it'll be really rich with neutrophils. All right. We said they're going to be in the hospital for 6 to 8 weeks minimally. It may be longer. They're really not going to move out of strict isolation until engraftment has taken place. And how do you think they'll know? How will the doctors, the oncology, nursing, and the doctors know when an engraftment is occurring? They got to check the CBC. Good. You can't visually see it. You can't measure it any way, but simply check a CBC at least once a day. They're going to be seeing is the neutrophils count going up and the platelet count. So, let's see how we're looking here. Engraftment, this is how, and you don't have to like memorize this. Engraftment occurs when the ANC, absolute neutrophil count, is 500 or greater for 3 or more days. So again, everyone's kind of holding their breath because we just wiped out this person's bone marrow. So we really pray that stem cells work. And then how do we know it's working? When they draw their blood every day and they see the absolute neutrophil count is 500 or greater for 3 consecutive days. Then they say, oh, engraftment is occurring. Also, when platelets are 20 to 50,000. So you know the normal platelets is what, 150? So we're happy if they get 50. So just think how at risk this patient is for bleeding, infections, and sepsis. They're on multiple medications prophylactically because, again, they have no white blood cells, they have no infection. So they're not only on antibiotics, they're on antifungals and antivirals because these patients are so immunocompromised. In addition, they're on lots of other medications to manage the severe side effects of leukemia. Complications of stem cell transplant. Oh, sorry. I'm sorry. What was your question?
For the ones, the autologic, where they give
their own autologous, yeah.
How does that work? Like, aren't you just giving them back to your cancer cells?
Well, I don't think they use it as much for leukemia. They use autologous for lymphoma, and non-Hodgkin lymphoma, and they use it for that, and multiple myeloma a lot more. So say you just get diagnosed, before you get chemo and all that, they would have them donate their stem cells, freeze it, for use at a later date. Because the benefit of your own is what? What's the benefit if you could get your own healthy stem cells? You're not going to have an adverse reaction, right? It's your own body. You're not going to reject it. But it's not. It can't be done for every type of blood cancer. Yes.
We're talking about stem cells. These are like fresh cells without cancer, so that's why we're using it.
Correct.
Oh, what is apheresis?
Apheresis is the machine, it's a process. Apheresis is a process where your blood is taken out and they filter out certain blood components and then it's put back in. So if you go to the blood bank where we donate blood and you're going to donate stem cells or certain cells, you go on this machine, and apheresis just means your blood is, it's almost like a dialysis machine, but it's filtering out certain blood components and putting the rest of it back into you. They also will do apheresis for certain treatments as well. So stem cell transplant, very rigorous, lots of side effects. The number one is infection and bleeding. Number one, number two. I don't know which one's worse, but they're both could cause the patient to die. Anemia, tumor lysis syndrome, ATN, but you could just cross that and write AKI, acute kidney injury, means the same. They can also have damage to their liver, kidneys, lungs. Veno-occlusive disease is like a disease of the liver that's associated with it. But the main complication specific to stem cell that you may or may not have heard the term is graft versus host disease, GVHD, graft versus host disease. So I'm sure you've heard about organ transplants, right? And that the people who get any new or foreign body, they have a risk of rejection, and they're on immunosuppressive drugs. But with stem cell transplant, it's a little different. It's kind of opposite what you may have heard about with a kidney transplant or a liver transplant. With the stem cell, graft versus host, it's the donated cells, it's the donated stem cells that are healthy, that go into this body that reject or react against the recipient cells. So that's different than what you know of other organ transplants, right? The other solid organ transplants is your body rejects the transplanted organ, right? But with a stem cell transplant, it's the donor cells, because basically we wiped out the patient or recipient's blood cells, right? It's the donor cells that reject the recipient. So it's kind of different than what you know. So that's called graft versus host, specific to bone marrow transplant, stem cell transplants. It can be minor or major. Most people who have stem cells have some degree of it, and that's okay. They can treat the symptoms. Or it can be severe that it kills the patient, and they could die of graft versus host. So how do we help minimize and reduce this? We give the immunosuppressive drugs, or anti-rejection drugs, I call them. So a major graft versus host would be like severe mucositis and diarrhea to the point that the patient loses so much fluid and nutrition that it could actually cause them to die. Also, it affects, you go to the GVHD. The main cells that graft versus host affect are the skin, the GI tract, the eyes, and the liver. So with graft versus host, those are the main cells that are first affected and affected the most. So again, it can be a mild form of it, which is okay. Actually, one doctor said to me, we almost want a little bit of it because it shows there's some immune response, right? or it could be severe and the patient could die. How do we prevent it? By using anti-rejection or immunosuppressive drugs like cyclosporin, tacrolimus. Corticosteroids are used. They'll be on high-dose steroids to suppress their immune system. They may have chronic symptoms that last for months to years to forever, which would be like, symptoms, but nothing they can't live with. Dry eyes, dry mouth, skin rashes. So with leukemia and stem cells, we're talking lots of interprofessional treatment, lots of support, a big team of specialists, right? Especially if we're talking about children. We talked about colony stimulating factors, abbreviated G/CSF, filgrastim or Neupogen. It's subcutaneous, given sub-Q, right? Have you guys, anyone given this? Neupogen or filgrastim. So it's subcutaneous, it's kept in the refrigerator. One of the side effects, it can cause bone pain. Yep, trying to kick up their bone marrow to produce more neutrophils. And the other side effects are listed here, and it is one of the drugs that has a chart in your assigned reading in Pearson.
Would bone pain be the number one?
Huh?
Would bone pain be the number one? Could you use
I don't know that it's number one, but I know that it occurs, because I know someone who did it, and they're like, God, my sternum hurts. And it was because they were getting a lot of nutrition. Neutropenic precautions. I do know you've heard about neutropenic precautions, because I believe the faculty told me that they talked about it in each lecture, right? But with leukemia, real important, because we're talking about cancer with the leukocytes, right? And we're talking about those leukocytes crowding out all the normal cells in that confined space where the bone marrow is. So they closely monitor their absolute neutrophil count. So you guys know there's all different types of white blood cells, right? Eosinophils, lymphocytes, monocytes, neutrophils. And then you heard about segs and bands. We're not lab technicians. I don't expect you to remember what percent of segs and bands. But remember, the bands are the newer cells. You don't have to memorize any of that. What I do want you to know is they monitor not just the white blood cell, but the ANC, absolute neutrophil count, which is a formula the lab will do. It's the total white blood cell count multiplied by the percent of neutrophils. Normally, 50 to 70%, so a big portion of our white blood cells are neutrophils, right? Because neutrophils fight infection. Some of the other white blood cells are involved in allergic reaction, right? Different type of infections, but neutrophils, which are 50 to 70% of our total white blood cells, fight infection. If the white blood cell count is low, the patient is at risk for what? Infection, right? So I don't know were you given a number when to put people on neutropenic precautions in your prior lectures? If the white blood cells less than what? Thousands. So here with the leukemia, we're talking if the ANC is less than 1,000, they're considered neutropenic. If the ANC is less than 500, they're severely neutropenic, which we're going to see with especially that first round of chemotherapy and stem cell transplant. Now, one thing I want to point out here, let's see. Yes. All right. See this superscript 3? See that? Cells over millimeter, right? You see that? So I'm just going to tell you this because you probably already noticed it, or you may see it on your testing questions. You know in lab results there's different units of measurements, right? So this is new, which I like. We're always going to give you the normal reference range. So it makes your life easier because you're always going to have the normal reference range. That's new, we just started this fall. Before that, people had to memorize it. So I don't have a marker, but. Oh, so another way that you're going to see the white blood cells is this. It's the symbol for micrograms, or micrograms, right?
Yep.
So you're going to see the symbol for micrograms or millimeters to the third. You're going to see that. Now, should this take up any space in your studies time? Absolutely not, because we're going to give you the reference range. So just look at the reference range. But I don't want people to be like, why does this say this and that say that? So, you know, in prepping this, I always over-research, and I've been teaching it for years. So if I took 10 resources, I got a lab manual, I got 4 different nursing books, I got a pathophys book, you're going to see both micrograms or MM to the third. Okay, so don't let that fret, don't worry about it. You're going to be given the reference range. Look at the number. It's just a different way to measure. In the lab book that I have, I think it's a Mosby's, they use the MM to the third. Okay, nursing interventions, you can read. I really want to get to our case study. What are the 3 priority problems with leukemia? Let's talk about leukemia first. What is the 3 main problems? Pathophys, abnormal cancerous leukocytes are growing and crowding out the normal cells. Cellular regulation, that's our concept. What? Okay, break it down into 3 problems for me. Pancytopenia. Neutropenia.
The marker's dead.
I know, you can hear me. Neutropenia, thrombocytopenia, and anemia. Is that what pancytopenia is? Broken down into 3 things? Neutropenia, thrombocytopenia, and anemia, right?
Yep.
Okay, that's pancytopenia. If you put that per number at the top, some problems, you should be able to come up with some interventions.
We're going to pass you down a marker.
No, I know, but you can hear me. Why don't you write it? So, neutropenia is low what? Neutrophils. We just had a little slide on it. ANC less than 1,000. Patient at risk for
Infection.
good. Neutropenic precautions, right?
Okay.
And number 2, thrombocytopenia is low. Good. Patient at risk for
Bleeding.
good. Number 1 intervention. Bleeding precautions. What does that mean to you as a nurse? Fall risk? Awesome. I didn't think of that one. That was the main first. What else? Good. Add extra pressure after they draw blood or do ABG. No extra invasive procedures. You want to take a rectal temp, not that we do anymore, but we used to back in the old days. So no rectal temps. Do you want to give people ion injections? No. Do you want to minimize injections? Yes. Right? Do we want to give them a sharp knife to cut their throat? No. Do we want to give them a razor blade? No. No. Do we want to send them out in the football? Send your kid that has leukemia, go play football on the football team or soccer? No. All right, so those are common sense. All right, neutropenia, thrombocytopenia. Anemia means low what? H and H, hemoglobin and hematocrit. Hemoglobin and hematocrit. If you're anemic, what are some interventions nurses could do? Iron supplement, what else?
Cluster care, kind of like cluster care, so they're
Cluster
not.
care, periods of rest, they're fatigued, they're tired, they're pale. Is shortness of breath a sign of anemia?
Yes.
Because now my hemoglobin, right? Hemoglobin carries your oxygen. So if I have low hemoglobin, I'm going to get short of breath walking up the stairs. I'm going to be pale, eyelids pale, mucous membranes pale, nail beds pale, I'm going to be short of breath, and I'm going to be tired. So now what I did was take one of the NGN style questions, case studies that you're gonna see on the NCLEX. So I think, now don't quote me, I'll look into it more. I think they said for each NCLEX, you're gonna have a minimum of 3 to 4 of these case studies. 3 is sticking in your head. And for each case study, there's six questions like that. So you're gonna have, not your whole NCLEX isn't gonna be, and you're only gonna have a couple. Because there's a lot of questions based on the case. So last time I did one with you guys that was like automated. So this is uploaded. I uploaded it so you could print it. All right, so here is our case. A nurse, some of you may have printed it. If you didn't, you could read it. Yes?
I know we're going to go through this, but what about the PowerPoint of skin cancer? Are we going to go through that?
Well, we were supposed to. I was supposed to have 2 hours, but they went over.
Okay.
So I will go over it as much as I can in 15 minutes. Well, did you guys look at the cancer? Okay, because I don't want to be the bad guy instructor with all the health sheets too quick. So one thing you'll know, pretty much everything you need to know is in my PowerPoint, and pretty much I'm not going to say anything different that's not in my PowerPoint. So if you do the reading, you have the PowerPoint, there should be no reason you can't answer any test question. But I will go over it. All right, so this is what you're going to see in NCLEX style questions. So underline or highlight, right, however they're going to do it, any abnormals. So that's the first place. And in the new way to think, it's recognizing cues, right? Recognizing cues. That's the new lingo they use. So multiple bruises, petechiae, child's leaning on mom, appears fatigued. There's a report that there's a decreased appetite and weight loss. Intermittent fevers, that's a big red flag, right? On the history and physical, we see the child had a cold and they're just not getting over it. So that's one of the first things sometimes you see with initial presentation. Someone just has an infection and they just can't fight it off, right? That's not just leukemia, other cancer. Sometimes that's how lung cancer is found. Someone has like a bronchitis and it's like 2 months later, they just can't get rid of that cough. All right, so this kid had a cold, they're just not bouncing back. Dry mucous membranes, multiple bruises and petechiae. So underline and highlight everything abnormal. Now, of course, we just finished the lecture, so it's like on your mind. But if it wasn't, with what you learned, it should be a suspicion now. So here is the vital signs. Again, underline or highlight any abnormal vitals or lab findings. So what's glaring out to you as abnormal on those labs?
Vital sign.
The white blood cells, the platelets, the
Patient has a fever, right?
Pulse is high, respiration.
Pulse is high,
Blood pressure is low.
not overly high. Well, 90 over 50 for an 8-year-old probably is okay. Stats are good, patient has a headache. What labs there are really concerning?
the white blood cells.
Look at the white blood cell count, 34,000. So what's our normal? 4 to 10. So that's really high. Even with a regular infection, usually we see 10 or 15. We never see 34,000. Well, of those 34,000 white blood cells, they're immature and they're irregular, so they're not functioning properly, right? The neutrophils, it says, we didn't write a number, but we know, and I said, don't get hung up on van sets and neutrophils. I don't want you to get hung up on that. Don't memorize a number.
But would you underline it?
Yeah. Yep. So I'm a doctor or a PRN or a nurse and I see, oh my God, this patient's white blood cell, this kid's white blood cell count is 34,000. My thoughts are gonna go to, there's some blood disorder here, right? And then look at the platelets. Extremely low, right? So this is, again, recognizing those cues and starting to think, based on your knowledge, what could this be? What sort of test are you going to anticipate as a nurse and interventions,
Are
right?
you gonna underline the RBCs?
Yeah. I never focus on RBCs, it's just me. I go right to H&H because I think, oh, hemoglobin, oxygen.
Yeah, but for the NCLEX, the big one, is that
Yeah.
underlined?
Yes, for the NCLEX, they're going to say highlight or underline the abnormals.
So just to confirm, they don't normally have center bands? Is that why it's on?
No, they will. I don't want to focus on that because that's like too much, because I'm not focusing on that.
Right.
But the lab will definitely check segs and bands.
So this is normal or not, the 10 and 50?
That is not normal. But you don't have to know that. I don't want you to focus on that.
Oh, okay, so just.
I know that you only have so much space and time to study, so I try not to have, like, I always feel bad if the student's spending time studying something. It's not, we're not gonna ask you what number of segs and bands is normal. I'll stick with white blood cells or ANC, absolute neutrophil count, right? Yes.
Do you think that's a question they would ask on the NCLEX though? Do you think that's something we should know? Like,
Segs and bands, absolutely not.
okay, thank you.
So I'm going to say to you, what findings are of immediate concern? Which are important but less urgent? So looking at those past two slides, signs and symptoms, what's immediate, like, oh my God, we need to do something, what?
Just pancytopenia.
Be a little more specific.
Well, the
White blood cells and the temperature.
Okay, the white blood cells and the low platelets, because you're like, oh my God, this kid, if he falls, he can bleed to death, or white blood cells, like, that's infection. Why are we worried about infection? What are you gonna die of infection? You get sepsis, right? You get sepsis and then you die. So this is another type of question, you know, to the best of my ability, I created it up there that you're gonna see on NCLEX, where you're gonna have some findings listed and then have to say, is it, you know, immediate concern or could it be addressed later? So temperature,
Later.
we can, yeah, we'll get some Tylenol, but we don't need to do a stat. Bruising,
Later.
later, because can we really affect bruising right now? No. But platelet count, I'm worried about it.
Yeah.
So I am going to make sure, right now we do bleeding precautions and protect. Fatigue, headache, and I think the first one said headache and sore throat. Anorexia or loss of appetite. That we're not going to, again, with the food, especially with children, they're like, don't get in a power struggle because you can't force feed them. But we're going to do what? We're going to offer frequent snacks, high protein snacks, soft foods, whatever they want to eat. So really, the most immediate thing here is that platelet count.
So like, that's kind of crazy because if you have a headache and you're suspecting that they might have leukemia and they have, that could be like CNS, but you can't get attacked because the platelet count is low.
Well, they're going to do a test.
But they still do it.
Yep, and they're going to, but then that's on the nurse. They're going to get a bone marrow. With those results, they're going to get a bone marrow biopsy, right? Maybe the LP they'll put off a day or two, but with that white count of 34,000 and those symptoms, right? The symptoms, the cues match a disease that we know is high risk kids, and the 34,000, they're going to get a bone marrow biopsy. So that means we're going to have to watch that site for bleeding and hematoma and high pressure. So check the problem that each assessment finding is associated with. Again, this is just those questions you're going to see. I just Wanted to try to get you used to seeing them. And I think we talked about it when we talked about that, but petechiae goes with, paleness goes with, bruises, fatigue, fever, and sore throat. There, you get down. So list the problems in order. What do you think is a priority problem? Yeah, I guess, I know, I was like, if I had to pick, don't worry, I'm not gonna. Okay, good, ABC. I guess I would say thrombocytopenia, bleeding, because those were very low, but definitely then neutropenia, risk for infection. So risk for bleeding, risk for infection, pain, the patient was right, and the patient, fatigue related to anemia. So in nursing lingo, like what is the patient's problems? Risk for bleeding, risk for infection, fatigue. All right, so what can we fill this out? The patient is most likely experiencing, and then they're going to give you choices. ALL, right? We just talked about it. We said that is the number one cancer in kids, right? No, CLL. No, ALL. ALL, acute lymphocytic leukemia. The nurse should first address what, followed by what? Yep, I would agree with that. So again, I did this based on the type of questions that are the new NGN, okay? So they're always going to give you options to pick from. Whether it's a drop down, a dragon, whatever, you can fill it out. Does anyone have any questions? Yes.
No, I have a question about petechiae. Is that related to the thrombocytopenia?
Yes. So one of the things I put in my section, I think another bit, was terms you should know, right? Back in the day, we used to have patients, students get the Tabor's dictionary. I have like 3 of them, it's my favorite. If I don't know a word, I look it up. So petechiae is a word, thrombocytopenia, myelosuppression, engraftment. These are words you need to know and look up if you don't know them. Rationale for providers' orders. Does anyone have a question about that? I just want to at least show you those. I would, and again, is there one set answer? Absolutely not. But they're going to do a bone marrow for sure, because that's what's going to tell them, is this leukemia, what type? Consult a pediatric oncologist, because we always want specialists for children, and there's special pediatric oncology centers. In Connecticut, Yale does pediatric oncology and CCMC.
When they're diagnosed as children, do they have a manufacturing plans in their life? Like, are they always being treated forever?
No, they might get a secondary from the treatment. Okay, so what interventions are appropriate for the nurse to implement? Select all that apply. But on the new testing format, it's actually better. It's going to say select 3 or select 4. So do you guys have a problem if I start using those terms in our exam questions now? No. So but basically, we're not going to do these drastic NGN questions. I guess we're not going to. I'm trying to make this 7 more minutes. So if you have to leave, I do get it. You have things. We're not going to do any drastic NGN format questions. I don't know if Professor Prada told you, but I guess that was decided. No, we're not. However, I would like to start using some of the terminology, and I think it'd be easier. rather than me saying select all, if I say select 3 or 4, then you know how many. Okay? So wait, I want, because then they're like, oh no, you can't change that. I'm like, why? So I said I was going to ask you. So are you guys all okay? Yes. The grading is not changing. So on the NGN questions, they're going to do partial grading. We don't have the ability to do that. Our testing platform right now, we cannot give you partial credit. So you either get it all right or all wrong. That's not changing. All right, so let's just pick, why don't we pick the 2 interventions that aren't appropriate up here? E and F. Which one? E and F. Does everyone know? We can give granulocyte colonies to F. So do we want to bring this child to the playroom to encourage mental health? No. Do we want to give intramuscular drugs? No. No. Okay. And now this is just a scenario a week later. Again, this is how they're going to do it. They're going to give you updated vitals. The answers?
But I think those are
Oh, okay. So what are the answers?
E and G. I thought you said pick 2. I thought D.
We said pick 2 that are not the right answers.
E and G.
Because the rest are right.
The rest are right. So 4?
Okay, so wait. Let's just use our common sense. So, do you think we should offer high-calorie, high-protein foods to any cancer? Especially kids. Do you think we should teach the patient and the parents about procedures, treatments, and side effects?
Yes.
So again, not just this kid and his parents, but every patient, right? Neutropenia precautions? Yes. Monitor CDC?
Yes.
Should we bring a kid that's neutropenic to the playroom? No. May we be administering Neupogen or filgrastim to increase neutrophils?
Yes.
Do we want to give anything intramuscular? No.
Yeah. So I just said something there. Oh, yeah, you're or email it.
That's a flyer.
Sure.
Did anyone feel, you know what, do you want to go through this or not?
No.
Okay. Yes or no?
Yes.
Okay. So I'm going to show, I can pull up the answers, but again, it's not, I'll post it on discussion. Okay, so I guess I could voice over the melanoma, but I really think it'd be me reading slides to you, so. You're adult learners. He said we're grown-ups. Okay, so the thing about the skin cancer, skin cancer is increasing in our country. There's many different kinds. The worst kind is melanoma, because that's the kind that can spread, metastasize, and kill people. So when we talk about treatment and everything here, we're focusing on melanoma. And the main thing, you can read about the AMP, but it's the melanocytes that become malignant, right? Melanocytes become malignant and grow and can cause a tumor. The risk factors are listed there. You can read them, but I bet you already all know it's UV light, so it's the sunshine in the tanning bed, that's the #1. There's different types of skin cancer. Certainly basal cell and squamous are much more common than melanoma, but we worry about melanoma because melanoma can spread, metastasize to the lungs, to the brain, and it can cause death. This is a really good picture of the different types of skin cancer. You don't have to memorize it, but when you're studying, do a little comparison. What looks so different and ugly about that melanoma, right?
The borders, different
The border,
colors.
so that's going to be something you need to know, the ABCD skin assessment. You need to know it as a nurse, and and that's what you can teach your patient, so I will show you that slide. I wanted to. So a good skin assessment is important, and teaching the patient how to assess their skin, even the back end, look under their arms, on the soles of their feet. People can get melanoma on the palms of their hands, the soles of their feet, even in their eye, there's melanoma sites. And the key thing is people that have multiple moles and freckles can be at increased risk. So they have to monitor to see if it's changing in size or color. So when you as a nurse do a thorough skin assessment, and what you're going to teach your patients is to use this ABCD guide. A means asymmetry, where the two sides are not the same, they're different. B means borders. It has, instead of a nice round regular border, freckle or mole, it has irregular borders. C is color. So more worrisome if it has color variety, like darker spots and lighter spots. D is the diameter. If this spot, mole, freckle, abnormal spot in the skin is greater than 6 millimeters, it's more suspicious to be a melanoma or skin cancer. And E means evolving, which is changing. So many of us have spots and freckles, and some of us more than others, right? So it's monitoring a mole or something. Is it getting bigger? Is it getting itchy? Is it oozing or draining anything? Is it changing? So changing appearance, size, or shape. So that A, B, C, D, E, skin assessment guide, you do need to know that. Skin cancer can occur across the spectrum. To know, we're seeing girls, especially with the tanning bed big craze, I think it's died down, girls in their late 30s and 40s getting skin cancer. So it is across the spectrum, certainly much higher risk the older you are, accumulating over time, but also with skin cancer, the more sunburns you get as a child, the higher risk you are. So even the children, it's really important to use sunscreen, SPF greater than 30, right? Even 45 are total for kids. Because even it said, like, even if they have 4 or 5 really bad sunburns as a child, that increases their risk of getting skin cancer. So prevention is big. Biopsies, a skin biopsy is how they're gonna, determine what type of cancer it is. Biopsying the tissue. And then if they think it's spread anywhere, they'll do PET scans and CAT scans. Staging, I think we talked about staging quite a bit. It has to do with size and spread to lymph nodes. So in situ means in site, it has a spread. You can read through this yourself. Stage 4 of any cancers always means it's spread, it's metastasized, and the prognosis is not good. This, I'm not going to give you any skin cancer questions that specifically talk to T and M. You probably heard it in another lecture, but specific to skin cancer, I kind of just want to have you see it again. Pretty self-explanatory. The treatment, I do want to speak. What's the number one treatment you think for melanoma?
Surgery.
Surgical removal, right? So ideally, if we could surgically remove the melanoma and take the margins of skin around it to get normal tissue to decrease the risk of spread, that's the ideal treatment. Wide surgical excision, meaning take not just the mole, but get the skin around it till you get to healthy skin. And if it's in the lymph nodes, they'll have to start checking the lymph nodes. If it's spread or extensive, like later stages, they'll definitely use chemo. Mohs surgery is specific to skin cancer. Again, you can read it here. but it's a tissue sparing surgery. So the surgeon takes some skin, they send it to a lab right there on site, and they look at it. And if there's cancer, they'll go and they'll cut a little more, bigger spot, and they'll look at it. So they'll keep cutting it right there while they're getting their results until they can get into the clean tissue where there's no more cancer. So that they only take what they need and they don't create a big spot. It's tissue sparing. It's called Mohs surgery. Used more for the basal and the squamous cell, but it can be used depending on how big the melanoma is. It's called Mohs surgery. And then as far as the pharmacology, yes, the targeted therapy and immunotherapy. And so many of the melanomas, not all, I think it said like 75%, they could specifically pinpoint to say it's a mutated BRAF and MEK genes, BRAF and MEK genes. So if you have a melanoma and they biopsy it and they look under the microscope and they say, oh, look at these are the mutated genes, you're going to receive a targeted therapy that targets that specific cell, okay? Again, you're not going to have any test questions that you can't find the answers on the slide or in your reading, okay? The PowerPoint's up there. I check discussion page every day and make messages, so you can ask me any questions.
Thank you.
Thank you.